With jury's permission, I shall start with the first presentation by Dr. Dikshit on flow diverter reconstruction for direct carotid cavernous fistula. Dr. Dikshit.
Good morning, everyone. My name is Dr. Dikshit. I'm an IR resident from Grand Government College, Mumbai. My guide is Dr. Avinash Gutte. And today I'll be presenting my study on flow diverter reconstruction for direct carotid cavernous fistula. And we have combined a pooled level analysis from literature and combined it with our single center experience. Brief introduction about CCF. It is a high flow shunt between cavernous IC and cavernous sinus. Typical presentation includes proptosis, chemosis, diplopia, etc. And the goal of endovascular treatment is to close the shunt while preserving IC and normal venous drainage. And currently there is a evidence gap because most of the published literature is based on small series and heterogeneous techniques. Also, patient level predictors and occlusion timings are unclear. Our study aims are the primary question: does flow diversion achieve high angiographic cure in direct CCF while preserving the ICF? And another question is whether a higher FD count leads to faster angiographic occlusion and better clinical improvement. Coming to materials and method. So we have done a literature review and we have found 64 cases that were published in PubMed, and combined that with our 8 institutional cases. The primary endpoints were complete angiographic occlusion, time to occlusion, and secondary endpoints were clinical improvement and complications. And statistical analysis was done to see if there was any relation between FD count with clinical improvement and time of occlusion. Coming to results, we had a total cohort size of 72 patients. The mean age was 43 years, and a primary flow diversion technique was used in around 65% of the cases, and most common etiology was traumatic, which accounted for around 60% of the cases, and genders were more or less equal with 42% females and 38% males. And coming to the methods used, only flow diverter was used in around 43% patients, and initial flow diverter followed by coiling of the cavernous sinus was used in 25%, and first coiling followed by FD was done in 22%. And only a single FD was used in roughly half the cases, and more than one FD was used in rest 50% cases. Coming to results, there was very good occlusion rate with 93% occlusion rate. The median time to occlusion was 105 days, and the largest group represented occlusion within 1 to 6 months post-treatment. Now coming to our statistical analysis, so we could not find any correlation between occlusion time and clinical response with the number of flow diverters deployed. And 73% of the patients had a good clinical outcome. 78% patients did not report any complication, and some of the reported complications were focal neurological deficit, IC occlusion or dissection, bleeding, and other problems due to dual antiplatelet therapy and SAH. Coming to conclusion, flow diversion for CCF shows high angiographic cure with a generally favorable clinical outcome, although the occlusion is typically delayed, most often occurring between 1 to 6 months. And additional flow diverters did not independently shorten the time to occlusion or clinical outcomes. So the device number likely reflects the lesion complexity and not direct occlusion rates. So FD alone was sufficient in half the cases, but many cases required adjunctive therapy. Coming to our limitations, this was an observational pooled report study, so there was a lot of confounding by indication, variable follow-up, and missing fields. And also we cannot credit the final cure only because of FD, because in a lot of the cases FD was used as an adjunct. And finally, one thing which we did not include in the etiology was whether any of the cases were associated with ruptured aneurysms, whether they are more difficult to treat like that. Okay, thank you.
Okay, so how many cases you have treated?
64 from literature.
No, your cases.
8.
8. So you treat only with flow diverter. In your center also you use other techniques.
We are also with adjuncts.
So other techniques also. How you decide which one you will put flow diverter first?
These were individualized,
How?
and those patients who do not need very immediate treatment,
Like?
and if there is severe vision loss, severe focal neurological deficit,
What is severe focal neurological deficit? What is severe vision loss?
if the patient is rapidly having
How many of your cases has cortical venous reflux?
in our one,
Hmm.
directly we have not included that, sir, in the.
Okay, thank you.
Yeah, that's a nice experimental study. Because I don't put flow diverter for direct cases, because you have an established form of treatment. And the most important thing what I feel is that for CC fistula is immediate reduction of symptom. Like what Dr. Reshmaya said, that cortical venous reflux or deteriorating vision, proptosis, chemosis. So if direct CC fistula, which is primarily draining into the inferior petrosal sinus, the patient might be having only tinnitus, nothing else, and the patient might not be bothered that much.
Okay.
And another thing in India is the cost factor, because once you have put a flow diverter or two flow diverter, that costs a lot of money. And once you put flow diverter in a direct CC fistula, you then only other way remains is that you have to go through the venous route and do that. You cannot directly enter into the fistula from the fistula side. So these are the limitations. So I would prefer to see more of CC fistula, which are indirect CC fistula, very slow flow CC fistula, which do not really have a good access. You see a little bit of chemosis and proptosis. The patient is really bothered about that, and there is no direct access rather than little bit of cortical venous reflux or maybe very slow flow superior and inferior ophthalmic veins. So those might be a good indication for kind of flow diverter or other things. Otherwise, for a direct CC fistula, I'm not very convinced about at this point of time that you go ahead and treat with such a costly device, and where you have also showed that there are complications. So that can only be justified if there is zero complication rate and it gives a very good cure. Then only that much kind of device is indicated. That's my
And
feeling.
also what I remember while I reading this CCF, average number of FD in the largest series was 5 or 6 to cure the fistula, and you are telling it doesn't matter. So it's not correlating with the previous study. So you are contradicting the previous study, because most of the cases they are not able to achieve anything with single FD. So that you have to keep in mind.
Okay, sir.
Do you know of any stent which is particularly used for CCF?
Stent grafts.
Any stent which exclusively came for CCF?
Balloon mounted FD Excalibur.
But that was also, we tried, but it is also not good.
Okay.
So, and the only thing you said that we didn't take into account that there is associated pseudoaneurysms. We have done cases, but again our primary mode of treatment for CCF will be standard only, either a transarterial or transvenous occlusion. And once the CCF is cured, for the pseudoaneurysm you can put a flow diverter. That thing you have excluded. That is the only indication that when you will do. Otherwise, the other thing is like you put a flow diverter and there is no transvenous access and still the fistula persists. Then what will you do? Then you have to put another flow diverter.
Okay.
So this is an experimental. Most of the papers, they come with 4 or 5 cases, but cannot replace the standard, but otherwise good.
Okay, sir. Okay, sir. Thank you.
Thank you, Dr. Dikshit, and thank you, sir. Next is Dr. Kribakaran, presenting on strategic endovascular embolization approaches in brain AVMs. I request Dr. Preeti to occupy the front seat for the next presentation. Thank you.
Good morning, everyone. Today I am going to present a series of 7 cases about AVM embolization done in our Barnard Institute of Radiology in the last 1 year. Myself, Dr. Kribakaran, and my guide is Professor S. Kalpana, and co-guide Dr. Periyakarappan. This is the first case. It's a 39-year-old male, already operated for AVM now again came with complaints of headache and seizures, and diagnostic DSA revealed persistent AVM in the left frontal region, measuring approximately around 2 centimeter, and in the left inferior frontal gyrus region, non-eloquent area, and supplied by the ACA branch and draining into the superior sagittal sinus. And while taking DSA of AVM, we should keep the frame rate at 6 so that we can separately visualize the artery and the AVM. This is the 3D images showing the AVM. And after wedging with the microcatheter, we will inject contrast to determine the speed of injection, and we embolized using Onyx 18. This is the post-embolization CT showing good percolation of the Onyx into the AVM. This is the 1-year follow-up DSA, which showed now the nidus came to a size of 4 mm, which corresponds to 70% reduction in the size of the AVM, and patient has no complaints. This is our second case. Is a 20-year-old male came with complaints of headache, feeding artery from left posterior cerebral artery, and draining through deep venous drainage, straight sinus and cortical veins, Spitzer-Martin grade 3. This case they referred from neurosurgery asking for pre-op embolization, so they could remove the AVM. And like prior case, this also embolized using Onyx 18. While embolizing, we should keep in mind mainly do under blank roadmap and to check for reflex. This is the post-embolization results. We embolized up to the footplate of the cortical vein. This is the intraoperative image showing the how much the nidus has shrunken, and the neurosurgeon told there is a 90% reduction in blood loss. They didn't even require a blood transfusion during the surgery. So this is the Onyx injection method. This case 3, this case is different from the previous 2 cases. This case has a very diffuse type of nidus. So it is very difficult to embolize these cases in a single sitting. So we planned for a staged embolization. And also this case received arterial feeders from all the vessels, bilateral, MCA, PCA. Through PCOM it was supplying. We thought of embolizing the most prominent left PCA. This is the 3D DSA image, and we plan for staged embolization. After the Onyx flowed into a different nidus, when the reflux was more, we just pulled the microcatheter, and it started filling the other half of the nidus also anteriorly. This is the final run, showing around 50 to 70% reduction in nidus. This is another 4th case. A 50-year-old male had a AVM in the right parietal cortex with the intranidal aneurysm as depicted by the arrow. The cases with intranidal aneurysm are high risk of rupture. So although this case was less than 3 centimeter and they were opting for radiotherapy, because of this aneurysm, there was a high risk of immediate rupture and patient going for symptoms. So we told and treated only the intranidal aneurysm and sent the patient for SRS. And, this nidus embolized using Onyx 18. It's a 1-year follow-up. After a patient went SRS also, the lesion was still 50% still present, but no complaints. This is another 17-year-old young patient with AVM in the left GC region, and this has numerous small feeders from the ICA, mainly supplied by the anterior choroidal artery and PCOM. And we embolized using Onyx 18 and marathon catheter. and deep venous drainage into the internal cerebral vein noted. This case, post-procedure developed right side hemiplegia, dense hemiplegia, and within 6 months with the physiotherapy, he improved symptoms. This is another 6 case, 9-year-old child with a AVM in the left quadrigeminal cistern, feeding artery from the left PCA, and similarly embolized. This is the last case, 23-year-old female with a history of cerebral hemorrhage and Vermean AVM with intranidal aneurysms as seen in the CT MIP images. And this also embolized using Onyx with a cast showing the post-procedure CT. These are the summary of all the cases. So the key learning points is embolization can be a standalone treatment and also can be used as an adjuvant for radiotherapy and surgery. Usually the radiotherapy takes 2 to 3 years to work. Before that, if the AVM has any high risk features of rupture, then we should advise them embolization and we should do embolization. And for surgery also, it reduces blood loss, and the surgeon can well visualize the AVM separately if we do embolization. And for larger AVMs, we should go for a staged embolization, 1 or 2 feeding arteries at a time. Most of the time, we use 18, Onyx 18. So, mainly AVM, we have not tried this pressure cooker or reverse pressure cooker technique because most of the cases the microcatheter got well wedged into the feeding artery and no that much reflux because we formed the proximal plug with the Onyx. So we didn't use these advanced techniques.
Okay, nice cases, but you have told this limitation you have not used, but actually sometimes depending upon the flow, you might have to change your strategies, and Onyx 18 is used in most cases, but again, sometimes we need a larger nidus is there, we need more percolation, then we may go for a low density, and sometimes if there is a fistula and we are very wary that immediately it can go to venous side, then we may have to use even a scepter balloon to reduce the flow, or you can use this pressure cooker technique. Yes. So the strategy depends upon the case, but otherwise for most of the cases it's fine. Which was the microcatheter used?
Marathon microcatheter.
Marathon.
So what I have observed in the cases what you have shown, the catheter is not wedged in the nidus. In most of the cases, it's in the feeding artery. Okay. And you have started injecting Onyx from a little bit away from the nidus. It's not in the nidus. How do you identify that the microcatheter is in the nidus? Do you know that?
When the venous drainage starts very faster, then we can...
Exactly. So what you have shown that, a lot of feeding artery we can see, and then the nidus, and then the vein comes. So it is mainly in the feeding artery. And at this point of time, in this sort of cases, what you have shown, we do not use Marathon at all because you cannot allow any reflux. So your injection will be premature. And that's why in most of the cases, you could not embolize. And why the follow-up DSA is after 1 year. It cannot be after 1 year. And in one of 2 cases, we haven't shown the post-embolization DSA, how it looks like. So those things are very important. So once the AVM is half treated, it's not treated. So you may not treat the whole AVM, that's understandable. But at the same point, you have to consult either the surgeon or the radiotherapy doctor so that you immediately send the patient for radiotherapy, and you cannot wait for 1 year to, the patient come to you again with bleed. So that's a wrong strategy. And this sort of cases, whatever it is, when you go for an AVM embolization in today's scenario, your primary aim is to cure. Primary aim is to cure. And it's not that the surgeon will take it out, you do some embolization. So this is probably not the right way to go at this point of time, because For the last 25 years, we are treating AVMs. So the strategy has to be cure. And if you cannot cure with embolization, it has to go directly to the radiotherapy or surgery, whichever way you feel, suitable. So yeah, otherwise it's a nice done study. Thank you.
Okay. Then one question, last question was a nice cases. So what is your post-procedure complication rate? How many cases you saw bleed after
Out of
embolization?
these 7 cases, only 1 case developed a hemiplegia. All other cases are fine only.
So what is the natural history of AVM as per Aruba trial? How many percentage of unruptured AVM they bleed in a year? Okay, thank you.
Thank you, Dr. Kirbakaran. Next we have Dr. Preeti. Dr. Snehal is here. Please have your seat.
Good morning. I am Dr. Preeti from Sri Ramachandra Institute of Higher Education and Research, presenting our 12-year single-center experience on telescoped flow diverters used for complex intracranial aneurysms. The real-world data on safety and efficacy of telescoping flow diverters is limited. We have 2 scenarios: planned elective overlap and rescue telescoping for intraprocedural complication such as flow diverter prolapse or slippage. We have retrospectively analyzed nearly 20 patients treated with telescoped FDs. We have analyzed the clinico-demographics, aneurysm characteristics, types of constructs, and angiographic occlusion outcomes as follow. Dual antiplatelet therapy was started 5 days prior to the procedure. Platelet inhibition efficacy was assessed. The occlusion degree of intracranial aneurysm was graded using the O'Kelly-Morata scale. Our imaging follow-up protocol was CT brain was done on the post-op day 1, and on a 1-month follow-up, CT brain was done, and on a 3 months MRI was done, and in the 6-month follow-up, angio was done. The results were like most of them presented with headache as a presenting complaint, and most of them had hypertension. Our cohort had aneurysm most commonly located in the anterior circulation, with ICA being the most common location. The aneurysms were most commonly unruptured, and most of them were fusiform types. Pipeline FD was the most commonly used FD, and the telescoping was most commonly planned in the elective manner. Nearly 2 FDs was placed in almost 15 patients, and more than 4 FDs was placed in a single patient. Adjuvant treatment with coiling was done in 4 patients. This shows the types of construct, that is proximal extension, in which the first FD once placed, the second FD is placed proximal to it, and in case of distal extension, once the first FD is placed, the second FD is placed distal to it, combined, in which proximal and distal extension was done, and one FD with another, which means like overlapping FDs. The most common construct was like proximal extension. The delivery wire was advanced distally, and the intermediate catheter advanced as much as possible prior to tracking the microcatheter through the first implant to ensure access in 5 cases. Second construct was of same diameter or larger than the first one to prevent a malposition in all cases. The second FD was overlapped for a length of about 30 to 35% with the first one for the final telescoping construct. Gentle stent plasty with wire massage to oppose was performed in nearly 3 cases. Outcome: all the flow diverters placed had a good apposition with the parent artery. Immediate occlusion rate was OKM-A3 in nearly 90% of the cases. Complete exclusion of aneurysm was achieved in 90% patients in 1-year follow-up and nearly 95% in 5-year follow-up period. Neointimal hyperplasia and the follow-up DSA was seen in one patient. Nearly 20% had major complications, with 2 patients had re-rupture, and 1 had intraparenchymal hemorrhage, and another had an infarct due to antiplatelet non-compliance. Case examples: this case shows an elective telescoping in which combined proximal and distal extension was made using 3 FDs, thereby achieving an OKM-A3 occlusion in case of an unruptured giant fusiform left cavernous ICA aneurysm. This image was a rescue Fred flow diverter placed in case of an unruptured fusiform basilar artery aneurysm where the first FD placed slipped into the aneurysm. Hence, it was overcome by placing another FD distal to it, achieving OKM A3 grade occlusion. This image shows multiple left ICA aneurysms in which the first FD placed was unable to cover the distal left ICA bifurcation aneurysm due to slippage into the aneurysm. Hence, another FD was placed distal to it. This patient on 7-month follow-up showed a suspicious slippage of the flow FD into the aneurysm due to flow diverter braid deformations. On the angio, there was persistent filling of the aneurysm with left M1 MCA stenosis due to neointimal hyperplasia, which was overcome by placing another FD distal to this. This shows both elective and rescue telescoping done in a single case in which 2 FDs were placed for an unruptured giant fusosaccular aneurysm in the left ICA communicating and bifurcation segment showed slippage of the distal FD into the aneurysm, which was overcome by placing another FD distal to it. This patient on 7-month follow-up had a left MC occlusion and presented with left MCA infarct, for whom mechanical thrombectomy was done with TK3 recannulation. This was mainly due to the antiplatelet non-compliance. This benchmark literature review study shows our study is almost comparatively showed similar results with Roy et al. Study where complete occlusion was achieved in nearly 90% in the 1-year follow-up and nearly 95% in 5-year follow-up, which is better than the other studies. Telescoping technical nuances, avoid telescoping in free segment, don't lose the support of the wire of the first FD. If significant angulation, lower microcatheter profile as possible. Can combine FD with other stents for apposition or hybrid construct. Sizing of second FD should be the same or larger diameter of the first one. Segment of telescoping should be at least more than 30%. Avoid telescoping over perforators. To avoid rescue FD placement, select the FD with good radial force. Give adequate forward tension to deploy fully. Avoid re-entry of microcatheter into the FD. Adjuvant coiling can prevent migration. But the rescue telescoping has fraught with the problem of ensuring that the exit of first FD is in the axis of the inflow or outflow vessels. Higher average neck length, more than 15 mm, is reported as a predictor of recurrence for telescoping. Conclusion, hence with the appropriate construct planning, imaging follow-up and strict antiplatelet compliance, we have achieved high aneurysm occlusion with acceptable safety profile. Thus, this study shows the safety, technical feasibility of using telescopic flow diverter technique in both elective as well as rescue scenarios. This enhances the flow diversion, tailored treatment for complex vascular anatomy, facilitates parent vessel reconstruction. Future studies are needed to refine the optimal strategies for applying FD's telescoping technique.
Okay, nice cases, but I think our strategy in our institute is to avoid telescoping as much as possible unless it is very much needed for a very large fusiform dissecting type of aneurysm or giant vertebral basilar type aneurysms. I saw many of your cases. I think many of them could have been done with the proper sizing of the initial flow diverter, and many recurrences could have been avoided if you have just put 1 or 2 coils in these cases rather than waiting for a recurrence and by putting another flow diverter. Because whenever we see such a large aneurysm, we take a long flow diverter and simultaneously we put 1 or 2 coils, which actually induces a thrombosis also and provides a little support for the FD also. But if it may be needed in certain cases, then we do it.
Thank you. It's a nice presentation. See, the single most factor why you have to either, your type 1, type 2 and type 3, these 3 categories of your indication was the length. Okay. So it is mainly the length of the FD was probably at that point of time was not that long, but nowadays we have 50 and 60 also. So you can do that. And the real telescoping is your fourth one, where it's a total overlapping. But why you did that? What was the indication of your type 4 telescoping? That one thing I want to know from you. And the second one is that you showed one case where there is a narrowing which has happened because of neointimal proliferation.
Yeah.
And you have put a second FD, this case. So how do you ensure that your neointimal proliferation will not be even worse after putting a second FD? So do you have any explanation for or solution with pharmacology to
with
have
shield
this?
technology, we put actually the
Okay.
third
But
pipeline
in our
flexion.
series, what we have seen, if you put those patients continue on dual antiplatelet, very high, statin, they resolve the neointimal
statins
proliferation.
also
They
have-
resolve rather than going and putting upfront one, because most of the cases that narrowing will not be clinically that significant.
But that happened because of the FTBD, flow diverter braid deformation. This was in the follow-up, and it almost prolapsed into the aneurysm.
It prolapsed into the aneurysm.
It was like flow diverted into the aneurysm, and the neointimal hyperplasia occurred in the which was not opposed.
Because of non-opposition.
Non-opposition, which was due to braid deformation.
Right. So but all the cases are very nice. And what was the complication actually?
20%
Complication rate.
had major complications, like one had a rupture on the, this is like retrospective study.
Yeah.
Before I have seen
Which
the
one
series.
ruptured? It's the anterior circulation or posterior circulation?
Anterior circulation.
Circulation ruptured. Right. Thank you.
Time's up, sir. Yeah. Thank you, Dr. Preeti. Next, Dr. Snehal. Dr. Seetam, please be ready. And followed by Dr. Sharath.
Good morning, I am Dr. Snehal from JJ Hospital, Mumbai, and I will be presenting on correlation between clinical, anatomical and technical factors associated with carotid artery stenting complications in a single center study. My guide is Dr. Avinash Gupte. Background: carotid artery stenting is a minimally invasive procedure for treatment of symptomatic or asymptomatic but hemodynamically significant stenosis at carotid origin. Very few studies have been published which correlate effects of demographic, anatomical and technical factors on clinical outcomes of carotid artery stenting, especially in Asian population. So our study analyzed effects of these factors on perioperative stroke, MI or death after carotid artery stenting. Purpose of our study is to establish correlation between clinical, demographic and anatomical and technical factors on outcome of carotid artery stenting so that necessary steps can be taken for prevention, early detection and treatment of complications. Coming to materials and methods, 106 carotid artery stenting procedures between January 2021 to January 2025 were included in our study. Clinical and demographic information, anatomical factors and technical factors of the procedure of these patients was collected and retrospectively analyzed. Clinical and demographic factors recorded were age, sex, presence of hypertension, diabetes, hypercholesterolemia, coronary artery disease, recent history of CABG or PTCA, congestive heart failure, smoking, chronic kidney disease and indication for carotid artery stenting. Anatomical factors recorded were site of stenosis, aortic arch type, calcification within the aortic arch, presence of CC origin stenosis, tortuosity of ICA, angulation of ICA from origin, associated intracranial ICA stenosis, length, location, severity of stenosis, and target site calcification. Technical factors recorded were use of embolic protection device, balloon before APD insertion, balloon before and after stent insertion, type of stent, length of stent and use of multiple stents. Primary endpoint of study were 30-day perioperative stroke, MI or death. Patients were evaluated immediately before and after the procedure, 24 and 48 hours after procedure, during hospital stay and 30 days post-op procedure. Logistic regression analysis was used to examine the correlation between clinical, anatomical and technical factors and outcome of carotid artery stenting. Coming to results, average age of population included in our study was 62.8 years. Our study included 84 males and 22 female. Out of 106 patients treated with carotid artery stenting, 8 developed stroke. Out of these 8 patients, mortality occurred in 5 patients and 2 patients developed myocardial infarction. Out of the 10 patients with coronary artery disease, 8 patients developed stroke, and major adverse events occurred in 9 patients, which included 8 patients with 8 stroke and 1 MI. Out of 8 patients with history of CABG or PTCA, 6 patients developed stroke and 7 patients developed major adverse events. 25% of patients with type 3 aortic arch developed a stroke, whereas 31.25% of these patients developed major adverse events. 22.2% of the patients with heavy target site calcification developed stroke and major adverse events. Concurrent treatment of associated intracranial lesion was significantly associated with the development of perioperative stroke and major adverse events, which occurred in 37.5% of these patients. The only technical factor which was significantly associated with development of perioperative stroke and major adverse event was PTA after stenting, which occurred in 14.7% of patients with stroke and 20.59% of patients in which PTA was done after stenting developed major adverse events. Logistic regression analysis showed a significant correlation between age greater than 62.8 years, coronary artery disease, recent history of CABG or PTCA, type 3 aortic arch, heavy target site calcification, and concurrent treatment of associated intracranial lesions, and PTA after stenting to be significantly associated with the development of perioperative stroke. While age greater than 62.8 years, recent history of CABG, heavy target site calcification, associated intracranial lesion, and PTA after stenting was significantly associated with development of major adverse events. Coming to few cases, 70-year-old female, known hypertensive and diabetes, presented with complaints of right-sided weakness 2 months back, which recovered within 1 week on DAPT. She had a history of recurrent right-sided weakness 1 month back. She had a history of PTCA 2.5 months back. So NCCT revealed acute infarct in the left parietal lobe and severe stenosis of the left ICO region. DSA showed left ICO region and ICO region stenosis. Embolic protection device was deployed in the distal ICA, and balloon plasty was done using a 420 balloon, and 840 mm open cell stent was deployed. However, next day patient developed right upper and lower limb weakness and slurring of speech. MRI showed fresh infarct in the left parietal lobe and occlusion of the left ICA. DSA revealed occlusion of the stent and filling of left ACA and MCA through the ACOM. The patient was offered a mechanical thrombectomy option. However, the relatives declined, and patient was kept on DAPT with aspirin and Brilinta. Clopidogrel genotyping test in this patient revealed high resistance CYP2 C19 allele, which significantly reduces active clopidogrel metabolite formation. Coming to case 2, 68-year male with complaints of left upper and lower limb weakness 1.5 months back and 6 days back. He had a history of CABG 2 months back. Right brachiocephalic angiogram showed occlusion of the right CCA, and left CCA angiogram showed moderate stenosis of left ICO origin and the petrocavernous junction. There was filling of right AC and MCA through the ACOM. Intracranial lesions were balloon plasted with 3 × 15 mm balloon, followed by insertion of 8 × 40 mm C-guard stent. Post-stent plasty was done with 6 × 20 mm balloon. After about 6 hours, the patient developed hypotension and slurring of speech and left-sided weakness. MRI showed watershed infarcts in the right frontoparietal lobe, basal ganglia, and multiple embolic infarcts in bilateral cerebral hemispheres. There was slow flow in the right MCA branches through the ACOM. Attempts were done to raise the BP of the patient with inotropes and vasopressors and crystalloids, however, failed, and the patient developed MI after some time, and we lost the patient. Coming to case 3, 78-year male with complaints of right upper and lower limb weakness since 1 week. MRI showed infarct in the left frontal lobe. There was severe tortuosity of the CCA, angulation of the ICA from origin greater than 60 degree with atherosclerotic ulcerated plaque at the ICA origin stenosis. The lesion was balloon plasted with 420 balloon, and open cells 840 open cell stent was deployed. After 2 days, the patient developed slurring of speech, and MRI showed embolic infarct in the left frontoparietal lobe. However, the patient recovered after a few days. Results. To summarize, clinical and demographic factors significantly associated with development of perioperative stroke were age greater than 62.8 years, presence of coronary artery disease, and recent history of CABG or PTCA, while age greater than 62.8 years and recent history of CABG PTCA was significantly associated with development of major adverse events in the perioperative.
Dr. Snehal, your time is up.
Anatomical factors significantly contributed to development of perioperative stroke, and major adverse events included type 3 aortic arch, heavy target site calcification, and associated intracranial ICF stenosis, while the only technical factors which was associated with development of stroke and major adverse events in our study was PTA after stenting. Conclusion: the primary complication rates were linked to both anatomical and complexity and technical choices. Statistical analysis identified key independent factors of complications: age greater than 60 years, history of CAD, recent history of CABG, PTCA, type 3 aortic arch, aortic, heavy target site calcification, associated intracranial lesion, and PTA of stenting were significantly associated with increased risk of stroke and major adverse events after carotid artery stenting. More research, especially in Asian population, is needed to refine risk stratification models and optimize procedural techniques for better outcomes. These are my references. Thank you.
Okay, thank you. So, what is your complication rate? Major complications. How many cases you had?
Sir, a total 7.5%.
So, how you decide which patient will go for endarterectomy, which patient you will take for stenting?
Sir, usually the high surgical risk cases like the recent MI or recent angina, COPD patient with CCF with reduced ejection fraction.
Any anatomical factors you consider? No, this case I won't do stenting. I don't like this anatomy. I know this is going to complicate. So, can you tell some anatomical factors where you don't do stenting?
Yes, sir. Previous history of neck surgery or previous radiation to the neck.
You showed one case, the 290-degree bend was there, one proximal,
yes,
one
yes.
distal.
Actually, sir, in our center, usually they don't, neurosurgeons don't do carotid endarterectomy.
So that's an indication.
So all the patients, usually we do carotid.
That's why complications will be more. And if suppose the patient has both intracranial as well as extracranial atherosclerotic disease, how we are going to manage that patient?
Sir, we should treat both the lesions.
Both the lesions? You should not. See, intracranial indication is best medical management unless it is recurrent.
Yes,
so
sir,
first
yes,
time
sir.
stroke
Yes,
patient comes, no?
Yes,
first
sir.
fix the extracranial atherosclerosis.
Okay, sir.
Then you can go for intracranial if it is recurrent.
Recurrent.
Okay, thank you.
Time's up, sir.
We can, talk a lot about your presentation, but because of want of time, I just want to tell you, see, at this point of time, after maybe, 25, 30 years that people are doing carotid stenting, you should not be doing 7.5% of complication rate, unacceptable. I know, I'm not telling you, I'm telling, for your understanding. But you have presented it very nicely. So 7.5% of complication rate, someone should not be doing carotid stent. Because at this point of time, there is an alternative like carotid endarterectomy, and none of the results of the randomized control trial, including CREST, has proved superiority. These are non-inferiority studies, not superiority. So if you think that you cannot do a good job, because if your complication rate is more than 2%, unacceptable, okay, you should not be doing. Other problem why happened is, you have chosen cases which probably should not be done. And the other is that your antiplatelet regime, I do not know what you have chosen. And then the selection of open cell stents, okay. So that's also another factor which is probably should not be done, open cell stent. Otherwise, the complication rate can be brought down below 1%, and that should be the one for this thing. So your protocol should be correct. You should be dealing with the standard technique, and you should grow by that technique rather than something doing. And what is your one indication that you will be sending for because you are doing every case, no? You are doing every case, carotid stenting. So if I tell you one case, you tell me that one or two indications that you will be sending to the surgeons, you will not be doing. You can send it to some other city, no? Because ultimately patient is a patient. You have to look for patient's life. It's not that in my center it is not that, then that's why I'll do it. It's not an indication. So tell me about two indications that you will not be doing.
Sir, difficult access to the target arteries like type 3 aortic arch and tortuosity of the common carotid arteries or intercarotid arteries, and heavy target site calcifications.
Right, thank you.
Thank you, sir.
Thank you, Dr. Snehal. I request Dr. Seetham to come over. Dr. Sharath, please be ready. Thank you.
Good morning, everybody. So today I'm just presenting over the reversible cognitive impairment which happens in dural AVF, quantitative analysis. This study was done in Department of Neuroimaging Intervention Radiology in Nimans, Bangalore, also with the part of neurology and neurocognitive department. So as we all are aware of what is dural arteriovenous fistula, there are a distinct group of predominantly acquired intracranial vascular malformation characterized by abnormal shunts between the dural arteries and veins, venous sinuses, also directly into it can be with the cortical veins. So clinically they usually very progressive indolent complaints to start with headache and ranging from benign symptoms like pulsatile tinnitus and also added severe complications like recurrent seizures, hemorrhages and progressive cognitive decline. So how the pathophysiology we know ki it starts with some etiological, maybe secondary to venous sinus thrombosis, or it can be other etiology. The first starts with venous hypertension, which leads to ischemia and hypoxia, which further lead to neoangiogenesis or angiogenesis, which further it can have two pathway, like it can have a benign outcome like collateral drainage and further the regression of the shunts, or it can be progressive into dural arteriovenous malformation, which further increases the venous hypertension with cortical venous reflux and more hypoxia, and that vicious cycles further go the similar way. So how this happens with the neurocognitive impairment? So normally with a higher grade of dural AVF like Cognad 2A plus B or 3 or 4, which will and 5, they will have a cortical venous drainage, and that causes like venous hypertension and chronic cerebral hypoperfusion, which vulnerable various critical regions of brain which are dependent on like sustained like perfusion or a oxygen requirement. This mechanism is already been corroborated by various imaging studies like them depending upon the perfusion and functional studies. So if you look into the pathophysiology, why we did this study to start with, when the patient present to us, the objectified how much years of complaints, which we are not aware of, though we have to objectify what is the neurocognitive impairment with the imaging finding. So given the serious implication of patient quality of life and the burden of long-term cognitive deficit, it is imperative to refine our understanding mechanism of these patients to recover from the after and the treatment of dural AVF. So the research question was, our goal was, does this embolization status in DAVF patient lead to domain-specific differences? I mean to say, when we do neurocognitive analysis, there can be a global analysis. It can be also various parameters inside the neurocognitive analysis. And are there any domain-specific changes which happens? And also, when we do the embolization, are they gonna change depending upon the domain? And by answering that question, we hope there will be contribution in the development of like various diagnostic and therapeutic protocols. Post DAVF embolization, we can have neurorehabilitation so that patient can recover even better. So this is a part of our long-term study in the initial 10 cases, which we did a prospective study. And the pre-embolization, post-embolization group, there is a variation 1 to 3 months follow-up with the neurocognitive analysis. Out of that, 8 are males and 2 are female with a mean age of 39 years and average formal years of education in the local language is 10 years. And all our cases are cognate like type 2A plus B, 3 dural AVF, 3 and 4 also, and 2 are 2A plus B, and 3, 4 are rest 8 cases. So all the cases underwent Adam-Brooks cognitive examination type 3 with a modified local language variation, and they have various domains like attention, memory, fluency, language, and visuospatial abilities, which was conducted in a standardized manner with the help of a neurocognitive technician. So, for example, in this case, one of the confounding factor here was all our cases were tentorial dural AVF. We have not included any supraesophageal sinus dural AVF or something. Here we can say this is the middle meningeal artery, and there is fistulous communication with the tentorium as well as cortical venous reflex. Similarly, these are the cases where tortuous cortical venous reflexes are seen as well. So the statistical analysis was primarily involved like mixed analysis of ANOVA variants, which were between the subject's factors like pre-ambulation and post-ambulation with the other factors like the domain ACE score, total score, as well as the 5 subdomain or codomains inside that. This approach actually allows to evaluate not only overall difference of global score, rather various like domain inside that, and also is that correlated with the tentorial dural AVF per se. To address this issue, multiple comparison and post hoc analysis also were done between the marginal estimated means, and also Bonferroni corrections were also done, and obviously the statistical significance were calculated. So if we see in the result, it is significantly there is a difference between the pre-embolization scores and post-embolization scores. Obviously the cognitive scores are improved after embolization. In further slides, I will go through the, like for example, this is the mean difference. I mean to say the total score of ACE of a pre-embolization and the post-embolization, that is the mean difference. Similarly with the attention, fluency, and language and memory scores. Out of this, the total ACE score and memory as well as the fluency, these were the clinically significant compared to the other 3 parameters like fluency, language, and language and attention. So if you see further into the variations of these parameters, when we analyzed with the vascular, because we have taken tentorial dural AVF, so we compared the total score, for example, in this like S3 total score, that is 78, in contrast that is a post-embolization score, in contrast to mean score of 52 in the pre-embolization group, and the substantial mean difference was 25 points, which is statistically significant, and the T ratio is 10, which suggests even more significance, that P is less than 0.001. Similarly, as we compared with the memory domain, which are also having significant difference of 20 compared to the pre and post. In the slide, if we say this is the total score in ACE, so in a pre-embolization group that was 52 mean and average, and the post-embolization it was 78. Similarly in memory, if you compare, it was 10.9 and it is 20.38 in memory, as well as the visuospatial, which is 6.4, which was improved to 12.6. So we analyze why there are 2 parameters which have a significant change, and rest of the fluency and attention comparatively less.
Time's up.
So if we say there are 2 things we thought, like if a memory is there, which might be because of the hypoperfusion, which further because of the perfusion improvement happens, so that's why the memory and total score improved very quickly compared to the attention and other like for example attention and language, which might have some neurocognitive connections which needs further long-term outcome to look for. And also the visuospatial was explained because of the tentorial, because it is more in the occipital lobe, that's why the changes were very significant. So our suggestions from this, we suggested like if patient which are not getting better in the cognitive post-embolization that can be followed with neurorehabilitation with stimulation of the frontotemporal or frontoparietal area for further improvement in the attention and other parameters. Thank you.
1 minute left for the juries.
Conclude. You can last slide.
Just so there are a few limitations to our study. Like first, the first thing, it is a small part of our long-term study, and the sample size is very small, and we have chosen only the tentorial dural AVF compared to the whole group of dural AVF. Another thing was the ACE3, which is various between the like the education, which is also a confounding factor of our study. So the take-home message is like the current finding of variable insights because of the reversibility of few cognitive impairment which happens in dural AVF, so that early embolization can help the patient recovery faster than adding neurorehabilitation, also better patient outcome. And further, obviously, there is need larger studies and multicentric studies to elucidate what is the cause of behind the neurocognitive impairment in dural AVF.
Okay, thank you. Nice presentation. So Sitam, 2-3 things. So have you noticed any correlation between the patency of venous sinuses with your recovery of cognitive functions? First. Second, why did you choose only the patients with tentorial DFF? And my third question is there an objective MRI marker which you can do during follow-up to document, yes, patient has improved neurocognitive functions?
So first, I have not checked whether antegrade venous drainage is there or not, but that objective I have not counted. Why I have chosen tentorial? Because there is a volume of 10 cases, because that is a part of prospective study. There are not a volume of other studies, so I have chosen that part of study, the data. And the final is we do ASL to look for there is residual is there or not. In that we assess whether there is residual fistula is present or not. By that we access in follow-up cases.
Okay. Thank you.
Thank you, Dr. Sitam. Next, Dr. Sharath.
A very good morning to all the dignitaries over here. It is my great privilege to present our topic titled Opening the Floodgates, Transforming the Treatment Paradigm of Idiopathic Intracranial Hypertension, a single institute experience with the transverse sinus stenting. Coming to the introduction, what is idiopathic intracranial hypertension? It is basically characterized by elevated CSF pressure of unknown etiology. So most commonly patient presents with nausea, vomiting, transient visual complaints, visual loss or pulsatile tinnitus. And the diagnosis is based on the modified Dandy criteria, which includes the symptoms of raised high CP and no localizing neurological signs except for the 6-nerve palsy, and neuroimaging features to exclude venous sinus thrombosis and hydrocephalus and any meningitis, and with increased CSF pressure of more than 25 centimeter of H2O. This is the MR features of IIH. The first one with dilated and fluid-filled bilateral optic nerve sheaths. The second image showing enlarged and empty cella. The third one with critical stenosis in the right transverse sigmoid junction. And the fourth one with the enlarged Meckel's cave. So what are the treatment options available? First is the lifestyle modifications. Next one, medical management with acetazolamide. Third one is the surgical management, which often with the optic nerve sheath fenestration or VP or LP shunts, which are associated with the significant complication rates. And the last one with the endovascular durous venous and stenting. So our institutional protocol. So once the IIH is established using modified Dandy criteria, before taking up to the patient, we'll stop the acetazolamide for 2 days. Post that, the loading dose depends. Post-pressure management, we usually take up for venography and manometry. We do it under local anesthesia so that the anesthesia medication does not intervene with our pressure changes. So once if the pressure gradient is more than 8 mm of Hg, then we'll convert it to GA and go on with the stenting. So when we are doing in such cases, we will load the patient on table with NG tube. We load dual antiplatelets, usually aspirin 150 mg and ticagrelor 180 mg. So access and hardwares. For venous manometry, we usually take the common femoral vein, venous and arterial axis for the venographs, and venous axis for the pressure management measurement. So once we cross the stenosis using a microcatheter, usually O27, and we measure the pressure across the superior sagittal sinus up to the IJV across the stenosis. If the pressure gradient is more than 8 mmHg, we do the stenting from the IJV axis. We take 8 French IJV axis through in the ipsilateral IJV. Then we take a long neuro guide sheath followed by a distal axis or intermediate catheter, and again we exchange it with O35 thermo wire or amplets based on the stent that we are going to use. Most of the time, if it is Protage or Silverflex, we usually use O35 wires. If it is a wall stent where we expect it to not propagate along the difficult course, we usually do it over amplets wire. And all the patients will be discharged with dual antiplatelets for 6 months, and after that we will usually put them on single antiplatelet for 1 year. So what are the general complications are expected to do this is most of the patient will present with transient headache. It is most commonly due to, most probably because of the venous stretching that happens because of the stenting, and in our experience we have seen this most commonly with epic stent and very least common with Zilverflex. Other complications like subdural subarachnoid hemorrhages and intracerebral hematoma we never encountered in any of our patients, and other general stent-resisted complications like stent stenosis or stent thrombosis or stent migration we did not encounter in our study group. So methodology, we had 18 patients which were retrospectively selected for the group. So all the patients with more than 8 mmHg pressure gradient across the stenotic segment went for elective sinus stenting. So what are the inclusion criteria? So patient diagnosed with IH according to Dandy's criteria with documented stenotic pressure gradient of more than 8 mmHg. And another special indication that we included in our study was the spontaneous CSF leak in a patient with dural rents. And exclusion criteria as such for any other stenting like uncorrectable coagulopathies and contraindication to dual antiplatelets. So these are the few examples. The case one with 34 years old female presented with headache and visual disturbance since 1 year. MRI features was suggestive of IIH. A patient was refractory to acetazolamide, which was on more than 6 months of acetazolamide treatment. So MRV is suggesting a stenosis at right transverse sigmoid junction. The same has been confirmed on venogram. This is the pressure measurement that we are doing manometry across the superior sagittal sinus into the IJV. So the pressure in the pre-stenotic it was 40 mmHg and post-stenotic 15 mmHg. The pressure gradient was 25 mmHg. So we carried on with the stenting. So this is final angiogram post-stenting. The important thing to note down is the pressure gradient. It has fallen from 25 mmHg to 2 mmHg post-stenting immediately. So this is another example. Case 2 pre-stenting, the pressure gradient was 22 mmHg. Post-stenting, it has fallen to 1 mmHg. So discussion in all our study group of 18 patients, of IIH, all the patients had very significant superior sagittal sinus pressure, and they presented with variable clinical signs and symptoms. So stent placement across the transverse sinus stenosis resulted in immediate normalization of the pressure gradient and symptomatic relief. All our patients were reassessed at 3 months, 6 months, and 1 year follow-up with venogram, and no significant post-procedural complications were encountered. This is our study group demographics. So it corresponds with the global demography that is most common in young obese females. And the most common clinical presentation we encountered that was the visual disturbance or papilledema, usually a Freshen scale more than grade 2 to 4. So all 18 patients of our study group had the visual disturbance and all had headaches, and 11 patients had pulsatile tinnitus and 2 patients had spontaneous CSF leak. So this is post-stenting clinical symptom resolution. So all the patients, that 11 patients with pulsatile tinnitus resolved within 3 months period, and papilledema over a period of 6 months, it has resolved in 94% of the patient, that is 17 out of 18, and headache resolved in 89% of the patient. So transstenotic pressure gradient pre and post-stenting, mean transgradient pressure was 18.6 mmHg, and post-stenting it was 2.4 mmHg. And this CSF rhinorrhea post-stenting, both the patient had resolved CSF rhinorrhea within 6 months. So This is one of the rare complication or an hardware failure that we had during the stenting. So this was a case we were doing from the common femoral axis. So this is during our initial transverse venous stenting. So because of a sheathing issue with one of our AUX guide sheath, the stent was partially deployed and got fixed to the guide sheath, and we were not able to completely deploy the stent, and there was also stent migration. So this is partially deployed stent with the stretched guide catheter. So we gradually pulled the stent along with the guide sheath, the whole system, into the common iliac vein, and we deployed the stent completely in the common iliac vein, and we completed this procedure again with an IJV access. So post this complication, we changed our protocol, and now if they are doing stenting, we do it directly from IJV access rather than doing from common femoral access. So this is the stretched and broken neuroguide sheath catheter.
Time's up.
So conclusion. So transverse venous stenting is promising in the treatment of medically refractory IIH for symptomatic relief and disease control with good patient profile. And our study showed resolution of clinical signs and symptoms like headache and papilledema, and even the spontaneous CSF post-stenting, usually within 3 to 6 months. However, the larger randomized studies are necessary, as our study population only included 18 patients. Thank you.
Thank you. Nice presentation, nice cases. Couple of quick questions.
Yes, sir.
So, suppose a young female, obese, came with headache, and MRI you have done, you found there is all the features of IH. How you are going to proceed? How you are going to treat?
Sir, if the patient is already, usually if it is IH and MR and clinical things, we'll put the patient on acetazolamide for 3 to 6 months. Post that it is still refractory, we take them for manometry. So only if the manometry is showing more than 8 mmHg, we carry on with this stenting. Because in this study group of 18, actually we had like 26 patients, where of other 8 patients, they had all the signs like IH features in MR and clinically, but the pressure gradient was less than 8. All of them had 2 or 3. So, these are not the ideal candidate for stenting.
Should be refractory. Should be refractory. Medical management is the first choice.
Yes, sir.
What is the cause of stenosis? What is the cause of stenosis?
Most of the cases, we couldn't identify the cause for the venous stenosis. Sir.
Giant arachnoid granulations? Chronic thrombus?
One of our case had no thrombus, sir. None of the case had any chronic thrombosis. Only one patient had arachnoid granulation, but it was not so significant to cause such a pressure gradient. Most of the cases, we couldn't make out any actual cause for the
There is
stenosis.
another hypothesis which say it's not intrinsic. This narrowing may be because of extrinsic.
Yes.
So how you differentiate that? If it is extrinsic, your stenting is not going to work, right?
Yes, sir.
So how
Yes,
you
sir.
are going to differentiate that?
Sir, if it is an extrinsic, as in we are seeing in MR or CT, so if there is any compression secondary to any of that, usually we will not take that case. It is not a case at all to take for manometry also, sir. Only if it is an intrinsic where you don't have any extrinsic compression, these are the cases we are taking for pressure management and followed by stenting.
What is the dedicated stent for venous sinus?
Sir, usually we are using Zilvaflex or Protege.
No. Do you know any stent which specifically designed for transverse sinus stenting? Means venous sinus stenting?
I'm not aware
And a
of.
reverse stent?
Yeah, nice presentation, but I'll tell you one or two things what we face. And if a patient is very rapidly losing sight, then what will be your approach? This is very important. And the other thing is that the site of stenosis is also very important. So if whatever cases you have shown is at the junction of transverse and sigmoid, and if your stenosis go more towards the proximal part of the transverse or at the junction of the superior sagittal sinus and the transverse, then you have to reconstruct the whole of the sinus, So otherwise what happens in one or two cases, it's my personal experience what I'm telling you, that once you put the stent, immediately you will see the stenosis is extending to the proximal area because the intracranial pressure is very high. And that's why we do not know what is the cause of stenosis, whether the stenosis caused the intracranial hypertension or vice versa. So that is one thing. And in 3 cases, we had to do associated VP shunt, because LP shunt doesn't work for a long time, VP shunt, and then only because it was extending, and we put 2 or 3 stents for overlapping and all those things. Then also we saw that proximal to the stent, again the pressure gradient is developing. So in those cases, what I feel, in all these cases I'm telling, they are rapidly deteriorating vision. So I feel in those cases, the better choices would be go for a VP shunt. Because once I put the stent, again you have to stop antiplatelet, anticoagulation, and then put VP shunt, and then and why did you stop acetazolamide? It can go along with that.
Yes, that is the ideal scenario is that with acetazolamide the pressure comes down. So you want to assess the
anyway, your acetazolamide is not working. It is not suppressing the CSF formation. So there's no point stopping it, because it might, it can add. And another is we use a single antiplatelet and anticoagulant, because the formation of clotting, it's not like the arterial stent. So you have to use one anticoagulation and one antiplatelet. Usually the literature says like that, and then it's better to do that.
Yes. So we also had a similar case wherein the stenosis was at close towards the proximal transverse sinus, wherein we completely reconstructed the superior sagittal sinus. But as you said, it was same thing. Every time we reconstruct one segment, proximal segment was increased. But post the second, this was like a 2-stage procedure where we did the transverse sinus stenting, pressure came down. Within 3 days, patient again developed headache. We went back again to see the pressure is increasing in superior sagittal sinus. We reconstructed the whole sinus. Then again, 3rd day, came back with same. But this is again the case of fulminant IH. But this patient was diagnosed later with cryptogenic meningitis. So that was the reason for all this. And post that treatment, patient completely recovered, and we didn't do any further procedures. Manometry later, after 6 months, was completely normal with no pressure gradient at all.
Right. So another point should be when you see the CSF opening pressure, if it is below 20, then probably the stenting is very ideal. And if you see CSF opening pressure is going 40, 50, you should go for direct VP shunt.
Fine. Thank you, sir.
Thank you. Next, Dr. Chirag.
Thank you. A very good morning. So the entire purpose of so the purpose of taking this to you is to generate the enthusiasm for another component of your training, which you should actually inculcate in your daily practice. So this is AI-based multi-level residual dual attention network, so a form of network for major cerebral arteries and aneurysm segmentation, automatic detection segmentation of aneurysms, which we did as a project. The grant was from the Department of DBT, Government of India, and Viruna, the Government of Sweden. Unfortunately, my fellow could not come here, so that's the reason I'm presenting here. So aneurysmal SAH, you all know, has the potential to cause devastating consequences. Accurate detection of an incidental cerebral aneurysm on CT or MR angiography is important so as to define treatment strategies and prevent catastrophe related to its rupture. In SAH, prompt identification of its source, commonly aneurysm, is important to institute appropriate treatment to prevent its re-rupture. However, at times, human shortcomings, misjudgments, and or atypical aneurysmal characteristics like small size, atypical location, variant morphology may lead to unacceptable inability to identify these aneurysms. Forget about treating them. Morphologically, you don't really know where the neck is. In this, you don't really know how much circumference of the artery is involved. In this case, you don't really know whether it is dissecting or saccular based on the morphology. So these are some of the parameters where, like in this case, who had aneurysmal SAH, there was spasm here, but it was very difficult to identify aneurysms on the 2D DSA. Eventually, a 3D DSA helped us in recognizing. So the entire purpose is to whether these algorithms can identify these aneurysms better than a neuroradiologist. Also, AI has of late caused deep inroads in medical practice, positively transforming its landscape, more so in the field of radiology. And AI-based machine learning and deep learning algorithms have the potential to improve detection of intracranial pathologies, leading to better patient outcomes. So artificial neural networks and convolutional neural networks based coding algorithms are being developed to identify, segment, quantify, and even diagnose and classify various medical disorders. So the aim of this was to utilize AI-based multi-level residual dual attention network to identify and segment major cerebral arteries, including the circle of Willis, and to detect, localize, define, and segment cerebral aneurysms. So this was a part of the generalized strategy that we are working on, the ultimate aim of which is to develop an automated pipeline for establishing comprehensive abilities to detect and quantify intracranial hemorrhages, including SAH, detect its causative factors, that means the aneurysms and other factors as well, define aneurysmal morphology, and develop tools to elaborate its structural details so as to improve functional clinical outcomes of these treatments, of these patients with endovascular treatment. So after obtaining institutional ethical clearance, 50 subjects harboring cerebral aneurysms were enrolled for training datasets, while another 20 for testing datasets. 3D time of flight angiogram, MR angiogram were obtained using Philips medical scanners, and all the datasets were anonymized before they were shared with our fellows who eventually coded these. So once we took the DICOM formats of 3D TOF MR angio, we transferred it to a software platform which is called the 3D Slicer. We annotated, the neuroradiologist, that means we annotated and labeled the circle of Willis and aneurysms. Few of these data sets were transferred to the training algorithm interface, and all were subsequently transferred to the testing interface of the codes developed. And all these results were verified by neuroradiologists. So this is a general protocol that is followed in the training dataset interface. You take these MR angiography volumes, generate the 3D angiography images, and what the algorithm does, what the codes do, is they take patches from within the center part of this algorithm, break it into numerous small algorithms and patches. This eventually undergoes through this network, which in our case was the multi-level residual unit facility. And these are eventually transformed by a process of deconvolution and reconvolution, where all the learning happens within these codes. And these eventually, the output patches are obtained, which are fused together to generate those images and identify the anomalies. So these are some of the networks available. This is the gold standard, that means we annotated it. So there was a stenosis here. But you see, in most of these algorithms, like unit, attention unit, residual unit, this is not really being picked up. However, this proposed network which we used in this presentation actually helped us in picking up and was very close to the gold standard that we gave to the algorithm. So the results, if we see here in aneurysm detection, were also good. So more than 70 to 80% voxel detection of aneurysms could be obtained. And unlike the other quantification parameters, statistical parameters that we use in our analysis of other pathologies, in this particular AI-based algorithm, these are the 4 quotients that we typically use. One is the dissimilarity quotient. It measures the overlap between the predicted segmentation, which the codes have done, and the ground truth, which we have done. 95 percentile Hausdorff distance, or the HD, which measures maximum distance between boundary points of the predicted segmentation, that means of the codes, and the ground truth. Precision, which is proportion of correctly predicted positive regions of the entire area which we have given to the code out of all the predictive positive regions, while the recall is the proportion of correctly predicted positive regions out of all actual positive regions. So if we see in the proposed network, which we did, the DSC, the dice coefficient was approximately 94%, which was much better than all the previous algorithms. And Hounsfield, the Hausdorff distance also was significantly less. That basically means that we are in a significantly better accurate zone as compared to the previous networks that were being used previously in the identification of these. Just to reiterate another table. So I would conclude by saying that this multi-label residual network performed better than existing networks in literature, and mind that these are all international studies validated, and we could achieve a very high DSC of 94%, lowest HD of 11.25, and with a variably good, I would say, recall rates. The network is capable of both local and global contextual features, leading to precise segmentation with smooth boundaries and minimal errors. By providing detailed aneurysmal morphology, these network models assist neuroradiologists to make quick, informed decisions about treatment, and may also be beneficial for follow-up of treated patients, especially the endovascularly treated coiled patients, which we know are prone to have higher recurrence rates. So we obviously can run in a certain, at a certain speed. AI networks are faster than us, we all know, but if we kind of understand these networks, we can actually go places. So these are some of my references. Thank you.
Yeah, excellent and latest, the trend, what is going on. So, sir, couple of doubts actually we have. So, suppose you want to commercialize it. Suppose you want to put it in a platform where people can use it. So, what next? What more things you have to do? Like you have done 150 patients. So, like more honest data means it will give more accurate output, something like that. So, first thing. So how you calculate the sample size to before going for commercial? First. And second is, what are the confounding factors which can give false negative values of these AI models?
Correct. So very, very apt question. So unless it comes to the clinics, it is of no use. It is just paper publication, that's it. But it is coming to use. Why? So there are certain fallacies. Why? Because our data may be different from your data. So what we need to do is we need to collaborate. We need to get data from multiple centers, multiple scanners, so that we can have the codes are actually trained on multiple scanners. So obviously the accuracy will increase. The second difficulty that we are facing when previously we did in brain tumor segmentation is industry partnering, which is a problem. Why? Because we being in medical national institutes, government institutes, it's very difficult to kind of handshake with the industry. So now the DBT has really provided platforms in which we can actually take industry in. So once we prove that our algorithm is working, the industry can work on it and generate it to a level that it is eventually useful for clinical settings. So that is one. The other question was the fallacies. The major fallacy is the person who is doing the marking the data, annotating the data. So if the data marked is wrong, obviously the generation of models will be wrong. But I must say that if the handling of the data marking is good, these models are very, very good to identify, and they are the accuracy that is provided is stupendous of these models.
We were planning for MRI diffusion stroke detection in our center. So we applied for ICMR. So let's see if we can.
That's very nice.
Do something.
Wish you the best.
Thank you.
Time's up.
Yeah. This is done in your institute primarily, or you are collaborating with some IIT?
No, we are collaborating with the IIT people, the IT people.
Yeah.
So we exchange fellows, and our fellows go there, they come here, and so that's how it's done.
Right. Okay. Nice.
But obviously, I don't expect people to learn coding, but you should know that it is possible, and you have to take the youngsters have to take it forward rather than the IT guys coming to us and asking for just
absolutely,
data.
Absolutely.
Thank you.
Thank you, Dr. Chirag. Next is Dr. Shikhar. Dr. Utsav, please be ready. And followed by Dr. Aditya. Dr. Aditya is here for the neuro intervention. No? Okay. Then we have two more candidates, Dr. Shikhar followed by Dr. Utsav.
Yeah. Good morning, everyone. I'm Dr. Shikhar, resident at VMMC and Safdarjung Hospital, New Delhi, and I'll be presenting on the topic of biology beyond the block, correlation of clot composition with technical complexity in mechanical thrombectomy. And the study was done under the guidance of Dr. Chirag Jain, Dr. Kavita Vani, and Dr. Charu Paruthi. So the outcomes of mechanical thrombectomy vary despite the patients having similar angiographic occlusions and the best of our techniques. So our little study tried to find out the fundamental cause behind this problem. So for a theory revision, so the clots are basically divided broadly into two types. The first is the RBC-rich clots, which are characterized by loosely arranged fibrin mesh with RBCs trapped, which makes them soft and deformable. So these are generally seen in cases when the patients have underlying atrial fibrillation or left ventricular thrombus, where the fresh emboli can form and then travel to the cerebral circulation. So these clots can show hypertense artery sign on the CT because of the presence of iron in the hemoglobin, and on susceptibly weighted imaging, they can show susceptibly vessel sign on a MRI because of the presence of deoxyhemoglobin. So these clots, because of their nature of being soft and deformable, are easier to retrieve. On the other hand, we have the white or the fibrin-rich clots. These are formed because of dense structure of fibrin and platelets with tight cross-linking, which is factor 3 mediated. So in this video that we can see that the RBC-rich clot is having lesser friction with the surface as compared to the white clot, which is showing an increased friction with the surface that can cause increased complexity in retrieval from the vessel. So the common sources for white clots are large artery atherosclerosis and in situ thrombosis in patients with ICAD. There is no specific feature that can be seen in fibrin-rich clots, but the absence of hyperdense artery sign can be a soft sign for the presence of a fibrin clot, and that can help us to plan the mechanical thrombectomy. So these are the mechanical thrombectomy, the retrieving of these clots during mechanical thrombectomy is often complex because of their firm and elastic structure. These clots can fragment and resist conventional stent retrievers, often necessitating the use of aspiration or combined procedures to achieve successful thrombectomy. So broadly, the difference between the fibrin-rich clot and RBC clot is that the fibrin-rich clot is mechanically stiffer, they are more resistant to thrombolysis, and they are often associated with longer procedure times. So why does this study actually matter? So this study helps us to explain that why some clots don't open despite having good technique. It helps us to correlate the susceptibility vessel sign or hyperdense sign with the expected clot behavior. It guides us in the choice of our first line strategy for mechanical thrombectomy, and it also helps us to look for the relevant etiological workup of the patient. So this is what we did in the study. So we retrospectively analyzed 6 anterior circulation large vessel occlusion patients over a period of 2 months, and the retrieved thrombi underwent microscopic fibrin RBC quantification. The procedural variables like occlusion site, recanalization time, the number of passes required, the technique, and the NIHS score were correlated using the Pearson and Sperman correlations. So the correlation with the clot composition with clinical parameters was as follows. So the older patients tended to have RBC richer clots. There was no significant consistent association was seen with the gender, probably due to our small sample size. In severity, the proximal occlusions were more fibrin rich as compared to the distal occlusion, which were more RBC rich. There was no meaningful association that could be established with the NIHS score. In procedure complexity, the fibrin-rich clots required multiple retrieval attempts, and the higher the fibrin content, there was increased reperfusion times. In technical and clinical context, the fibrin-dominant clots often required combined techniques for retrieval as compared to the RBC-rich clots, which were frequently retrieved with aspiration anode. So in technical complexity, the fibrin-rich thrombi required more device passes and longer onset to recanalization time. In one of our interesting case, it required 8 passes, and the fibrin content in that was 80%. And when the clot was sent for histopathological examination, we can see that the clot is having few RBC areas, the red areas, and the fibrin is predominantly seen, and the intima and the media of the vessel was adhered to it. So basically, the clot was so much adhered to the vessel that it required 8 passes for us to retrieve that clot. So for key correlation, the fibrin content inversely correlated with the occlusion site. So the higher fibrin proportions were seen in the proximal segments as well, and the RBC-rich clots were seen in the distal segments. So this was the the onset to retrieval time that was seen. So we can see that the fibrin with 80% time was showing 434 minutes from onset to the recanalization. And this is the correlation between the fibrin content to the occlusion site. And we can see that the RBC clots was seen in MCA, in the superior division of the MCA. So one of the case in this, we can see that there are more RBC areas in the HPE. The clot composition was 40% fibrin with 60% RBCs. The first pass to recanalization time in this patient was approximately 2 minutes, and the technique that was required was only aspiration. As compared to that, in this we can see that there are maximum areas are seen fibrin rich. The fibrin was 90% in this case with only 10% RBCs interspersed between. The first pass to recanalization time in this patient was 102 minutes, and the technique was Solumbra plus balloon guided catheter. So we have already seen this, the imaging and histology. Basically, the hyperdense artery sign and the blooming artifacts on MRI are more related with the RBC dominant thrombi. Absence of hyperdense sign can suggest that the patient might have a fibrin predominant clot. So the comparison between our data with the literature that is already available. So we can see that the RBC rich clots had faster time, which was also seen in our case. The fibrin rich clots showed longer times, which was also seen in our study. The occlusion site, the proximal were fibrin rich, as seen in our study as well. So our data reinforced that prior large stage findings that clot biology, not angiography alone, drives the thrombectomy complexity even in the small cohort that we had. So for a representative case, there was a 40-year-old female patient with left-sided weakness for 2 hours. The NIHS score of the patient was 6 and the time of onset to arrival at our hospital was 141 minutes. So the first pass to recurrence time was only 3 minutes. So we can see a hyperdense artery sign in the right MCA. The occlusion is also seen on the angiography and the DSA images. This was the clot that we retrieved, and the clot composition was 40% fibrin with 60% RBC. Here we can see that the clot is seen in the right MCA. Only aspiration was needed, and we have a very good canalization post that. So the clinical takeaway is that clot biology is the key determinant of procedural difficulty. So fibrin heavy thrombi may benefit from combined or assisted techniques. Aspiration alone is effective for RBC dominant clots. So for conclusion, the clot composition significantly influences the thrombectomy complexity. Understanding the thrombus biology supports in our precise endovascular therapy. Thank you.
Nice presentation. It's a well-known fact now in literature that the fibrin-rich clots can be quite resistant. So what will be your go-to strategy based on CT angio alone? Now you have seen this retrospectively, so after learning from all this,
yes, sir.
If you encounter a case with not having a hyperdense sign, would that change your strategy?
So we can keep our additional stent retrievers in backup as well, at least because stroke is an emergency case, and the patients at least coming to our institution have a financial problem as well. So basically, if the hyperdense artery sign is not present, we can at least have the thought that the retrieval can be difficult, and we can at least keep the stent retrievers for backup. And one aspiration we can give with the large bore catheter, and if that is not there, and then we can go with the additional attempts with stent retriever.
For us, if given a choice, we'll like to go with both together rather than, because these RBC clots are used with stent retriever, there's a chance of distal migration.
Yeah, right.
Because they fragment.
So
given a choice, both should be used, or a BGC should be
BGC should be used for proximal.
But of course, there are financial constraints,
yes,
and
sir.
We may have to limit sometimes.
Yes, sir.
Yeah, nice presentation.
Thanks, sir.
So, so we can see that there is a lot of variability between the techniques. In some institutes, they use aspiration, some stent, and some use both.
Yes, sir.
But the usage of balloon guide catheter is very less actually nowadays.
Yes,
they
sir.
don't use much of balloon guide catheter because of the complexity of the usage. And yeah. So did you encounter any intracranial atherosclerotic lesion in those cases of the white clot?
Yeah, so there was one case with ICAD in that patient. So, and that came out to be a fibrin clot as well with, I think, so.
So what do you think is the origin of that white clot?
So basically the thrombus rupture can be the origin of that clot. The thrombus ruptures and then the clot is formed in that artery only.
Absolutely. So in a majority of the cases, probably there is some sort of an atherosclerotic lesion,
yes, sir.
either in the neck or there, up there. So that is the main reason for all this.
Yes,
but in most of the centers, I feel they use mainly the combined technique of aspiration. That is the best technique.
Yes.
Thank you so much.
Thank you, sir.
Thank you, Dr. Shikhar. Dr. Utsav is here. Do you have Dr. Aditya Ajit here? No, thank you. I request interventional oncology case presenters or the paper presenter to be ready with their presentations in their pen drive, please. We'll start it in another 15-20 minutes. Thank you.
Very good morning, everyone. Today I'll be discussing transalnar access in the underrated route in the era of radial dominance. I am Dr. Utsav M, Junior Resident PGI Chandigarh. My guide is Bikas Bhatia and Sarfaraz Ahmed, PGI Chandigarh. So transfemoral artery has traditionally been the standard access for interventional procedure, but due to increasingly, transradial access is increasingly favored due to better safety, faster recovery, and fewer complications. Despite advantages of transradial access, it may be limited by small vessel caliber, anatomic variations, vasospasm, and radial artery occlusions. In those cases, transalnar access has emerged as a safe and effective alternative where radial access is not feasible and maintaining the upper limb approach. So we had conducted a retrospective study where it included patients from January 2024 to December 2025. We included around 9 patients, out of which 6 were male and 3 were female. Clinically, we had indicated indication, demographics, and procedure type, whether it was a diagnostic or interventional therapeutic. Radiologically, we have checked for diameter of radial artery and ulnar artery, vessel patency, and target vessel territory. We have used ultrasound guided puncture and DSA for completion of the procedure, and we have used 4 to 5 French catheter for diagnostic and 6 French for therapeutic procedure. Success-wise, you have checked technical if you completed the procedure or was there any crossover to TFA. Clinically, you have checked if there was any access site major complications. So we had included patients ulnar diameter of 1.8 mm. Right ulnar artery was favored over left ulnar artery, and arm was positioned at 10 to 15 degrees from the body with hand in supination and hyperextensions, as like transradial access. Monitoring equipment, essential drugs, and pulse oximeter were kept handy. We did not do modified alien stents in our institute. So after ultrasound guided puncture and sheath was placed, we have given a cocktail of nitroglycerin, diltiazem, and heparin to prevent any spasm. After completion of the procedure, we have done compressive dressing or radial compressive device to achieve hemostasis, and instructed the patients to limit limb movement for next 2 hours. So this is the case of 67 years, which we did a diagnostic cerebral angiography for a ruptured AVM. Here, transalnar access was taken due to radial artery occlusions, and you could finish the procedure in less than 17 minutes, which is mentioned here. And this is the second case, the 46-year female. We did a therapeutic cerebral angiography due to cerebral vasospasm. Here, transalnar access was taken due to small radial diameter, and here also we could finish the procedure in less than 9 minutes here. We have done 9 procedures, out of which 7 were diagnostic cerebral angio and 2 were interventional therapeutic procedure. And the main reason for transalnar access here was small radial artery diameter, which contributes to 67%. And we could finish 9 out of 9 procedures successfully without any major complications. In inter-procedure, we had 2 patients mild angiographic spasm, and 1 patient complaints of pain at 1 month, but relieved after giving NSAIDs. So transradial artery is considered for a feasible safe access. Then why are you thinking of transalnar artery? In some cases, as I already mentioned, radial artery vasospasm, radial artery occlusions, anatomic variants, loops, tortuosity, and high bifurcation, perforation, pseudoaneurysm. In those cases, you have to think of alternative upper limb approach. Here is a patient of 45 years who presented with a severe pain after diagnostic catheter passed through the radial sheath placed in radial artery. And the second case is an anatomic variant of radial artery, and third is a brachioradialis variant where a radial artery originates high up from brachial artery or even can origin from axillary artery. In those cases, you have to think of alternate access like transalnar. So if you see transalnar access, there are many advantages, or there are also limitations. Advantages: we have lower incidence of vasospasm as less adrenergic receptors, lower arterial occlusions rate, few vascular loop, and favorable anatomy. In limitations, we have steeper learning curve. Ulnar artery is deeply located, so hence difficult to cannulate. And obviously, we do have limited literature about this. So here I want to mention, we have done a lot of in our institute, we have done a lot of transradial access cases. And we have published many literature. I had to show you here. So here I want to mention steeper learning curve is present in transalnar artery, but operators who are familiar with transradial access, it can have a smaller learning curve. So these are the recent literature which shows that about transalnar access, which shows around near 100% success without any major access site complications. And our study also is mentioned here. So in conclusion, transalnar access offers a comparable technical success with minimal complications. Ulnar artery status course provide an advantage over TRA, and it may have a shorter learning curve for the operators familiar with TRA, And we are not trying to prove here that we have to replace transradial access, but if transradial access is not feasible, we can go for transalnar access, maintaining the upper limb approach. Thank you.
Thank you, Dr. Utsav.
Nice presentation. One case you have shown that the radial artery was occluded.
Yes, sir.
Okay, and then you went for the ulnar.
Yes, sir.
Okay, so in that one, like, why you went for the ulnar? Because if the ulnar gets damaged, or it gets dissected, or it gets occluded, then the limb will be in problem, no? So why don't you go for the opposite side or go for the femoral? What is the rationale in that one? Other I understand.
Yeah, we wanted to maintain the upper limb approach where
it is more than the safety of the patient.
Here this case, here this case, the hand perfusion was good, and we wanted to maintain the upper limb approach to prevent. We wanted to see if it could good for this.
Sir is asking that why couldn't we use? You want to, maintain the upper limb access, but we can have that from the left side also. Do you know literature? If a radial artery, is there any literature that if radial artery occlusion is there, do not use ulnar access? Or both are small, then don't use?
I didn't get you, sir.
Is there any literature to support that if one of the arteries is occluded, then like radial artery is occluded, then do not use a ulnar artery?
Yeah, it's mentioned in.
No, in literature.
No, sir.
So actually, in literature, it is said that the hand has very good, collateral circulation, and even if one artery is small or occluded, also literature review had shown that it can be easily used. So it is not actually contraindication, but yes, it can be avoided and can be done from the left side.
Thank you, sir.
Thank you all. The neurointervention paper presentation session is over. Now we will proceed with the intervention oncology. Thank you for the juries who has chaired for the neurointervention session. Thank you, sir. Candidates with the intervention oncology can bring their pen drive to upload the PPT. The permission of the juries, I will be starting the session. First will be Dr. Amrin, please come out. Followed by Dr. Prabhojit Singh, please come to the front line and have your seat. Then followed by Dr. Varun. Sir, we will allot 5 minutes plus 1. 5 minutes plus 1. We have 11 candidates, so 5 minutes plus 1. Question and answers. 5 minutes for the presentation plus 1. Yeah, it was 8 because there were less candidates. Now we have 11 candidates for the same time.
So one of the candidates is missing, so we'll give them 6. Of course, we have all prepared according to that.
Agree. So it has to be timing based on number of candidates. Sorry about that.
So Vaibhav is not presenting, so we can.
Take it.
Amrin, presenting data from Guy's and St. Thomas's, a fellow working there. So I'll be talking about fluoroscopy-guided tracheobronchial stent placement in central airway obstruction, a single center experience. No disclosures, no conflicts of interest. So a bit of background. The tracheobronchial wide stenting is basically an effective palliation strategy for central airway obstruction, especially in patients who have malignancies that involve the carina, the distal trachea, and the main stem bronchi. The compression can be extrinsic or intrinsic, and it helps to alleviate symptoms of dyspnea, improve the quality of life for these terminally ill patients, more often than not, and it can be used as an adjunct for laser ablation, cryotherapy, photodynamic therapy, and for management of endoluminal lesions. Before we go ahead forward and delve into the topic deeper, it's always good to touch base with history of how it all began. So it started with simple silicone stents, as we can see here. That's how the procedure initially began, and it was usually done through a Montgomery T-tube, a picture of which you can see on the side. But these stents were not very flexible. They were difficult to track. The migration rate was high, the reocclusion rate was very high. So then came in the SEM stent, the ones that we place, the nitinol ones everywhere in the body in IR, similar to those with silicone covering or without the silicone covering. They are much easier to track. If you use a covered stent, then there's the advantage that the tumor in growth is much less in these cases. So what we did was, from a big cohort of patients, we selected out 21 patients who typically only underwent the Y stent placement, not the kissing stents, in the last 6 years. The multidisciplinary team included respiratory physicians, interventional radiologists, and anesthesiologists. Inclusion criteria being inoperable malignancies or post-surgical complications, and also patients receiving concomitant radiotherapy or chemotherapy. IR is all about innovation, small to big. That little clip there, which you can see, is a U clip, basically, which is available everywhere. I'll just tell you why we use it and where we use it. What we do is a combined procedure with bronchoscopy and fluoroscopy. So we have the general anesthetic, we have the respiratory team. They put in the rigid bronchoscope. They mark the carina at the bifurcation. The C-arm comes in, we do a fluorospot, place the U clip just on the chest, and tape it to the patient's chest. So it's more like you're completely, kind of trying to be fail-proof, where you have a landmark on bronchoscopy and you have the fluoroscopy landmark. The bronchoscopy also helps in facilitating mucus removal, biopsy, and ablations as well. Patients usually undergo stenting over stiff wires, and a chest X-ray is performed at 24 to 48 hours to look for expansion in position. The complications that we evaluated for were migration, obstruction, poor patient tolerance, perforation, and stent fracture. Now, there are lots of stents in the market. The one that I'm going to be talking about is just a basic technique on how we do it and what this basically Y stent means. So if you see the stent design, I don't know if this is working. Okay. Yeah, so if you see the stent design, okay. So what I want to show you is, this is a blue colored marker and the white colored marker there.
Ma'am, you can use the cursor.
Oh, thanks. Yeah, so the blue colored marker and the white colored marker, each of them signify the right and left bronchus, which is very important when you're doing any sort of a bilateral thing, You need to know which wire is coming out from which port and which part is what you're deploying first. So the part basically has a blue and a white marker there, and then you have a white and a blue marker at the end. So the white represents the right side and the blue represents the left side. Now going forward, what happens basically in this procedure is, so you've identified the occlusion or the lesion at the bifurcation. The rigid bronchoscope comes in, and then you use your standard J wire, a hydrophilic wire, and a catheter. That is the small U clip that you see, which is placed at the bifurcation of the carina. You cannulate each of the right and left main bronchus with hydrophilic wires. Once you've done that, selectively, you exchange it for stiff Amplatz wires. Once that's been done, so it's just an image showing that. But you need to remember that the right and left, you need to have some way to identify which wire is what. So we usually have these sticky tapes, red and blue colored, which we keep on each side to know that this is the right and that's the left wire. So you see how it has two catheters within loaded, and the whole thing goes on two different wires down. You place it like a centimeter proximal to the carina. So you have your clip there, which is telling you where you are. Ensure that that doesn't happen. So you have to detangle it, because that will otherwise not end up in an appropriate deployment. Then what happens is you basically unsheath it, advance the two limbs, and then do a gentle forward tug, and then independently, so that's a gentle forward tug, which is important that you're wedging it on the carina. That's a technical aspect of what the procedure is. And then you independently deploy each of the ports. So that is what happens. And then you finally deploy, once you're happy with the deployment, you finally deploy the whole bit of the stent. So that's the last bit of unsheathing. So that basically in a gist is what a Y stent is. So this is the first patient, a 50-year-old gentleman who's come with a millicentral airway obstruction, more on the right than on the left. That's how the stent has been placed. This is another fluoroscopic image which I wanted to show on how the whole stent works. I'm not sure if the video is working. Apologies for that. Okay, apologies for that. I think the video is not working. But what I wanted to show here is separate deployment of the two limbs. That little U pin is at the carinal bifurcation. So you know you've deployed the two limbs. You come up until there. You're happy with the placement, and you deploy the main stem of the stent eventually. So technically, that's the procedure. This is another patient. You can see the chest X-ray. You can see the malignancy. It's a necrotic mediastinal mass in the posterior mediastinum. Lots of compression. So in this particular patient, we decided to go with a Y stent, but sometimes it's not the easiest stent to track. Like you saw, it was a bulky system. So we couldn't track the whole stent apparatus into this patient. So we had to take it back, and then we had to deploy it separately.
Time's up.
You mean the last minute? Yeah. Okay, I'll just go to the last slide then. So 18 and 20 millimeter diameter, just some take-home messages on what, the prognostic factors would be distal airway patency on bronchoscopy. If that is present, then it's a good prognostic factor. Technical success being 95%, procedural complication rate being 4.7%, only in one patient who couldn't tolerate it, so we had to take the stent out, but good response, so we didn't have to put another stent in. Multiple studies that say that it's a safe procedure, can be performed in a multidisciplinary setting. Future prospects being drug-eluting stents, biodegradable stents, and radioactive stents loaded 125 iodine, which have good potential to inhibit the persistent growth in malignant tumors. Those are the take-away messages. What I would say is it's a procedure not technically very challenging, a little bit of a learning curve, can be safely performed by IRs in combination with a respiratory physician and anesthesiologist. Happy to take any questions.
What are the best candidates you will feel, you predict that the outcome will be the best? Of course, you have pointed the distal airway disease.
Yeah.
Besides that, anything else?
Distal airway disease, and plus if the patient is, you mean technically or clinically? Clinically, I would say, technically, if the distal airway is patent, that's a good sign that the patient, the Y stenting can be done, in my experience. And it's not a tight stenosis. If it's a very tight stenosis, Y stent will not track. Probably we'll have to do the separate kissing stents. Dr. Tarun, is there anything else you feel?
What about...
is there any difference between external compression or internal, something is tumor, let's say tumor is occluding, or it is external, any difference in overall?
Trackability will be very poor if it's an intrinsic.
I'm asking about the clinical outcome.
Clinical outcome. Extrinsic, I think, respond better. I don't have vast experience in it, but the ones that have extrinsic compression respond better than the ones who have intrinsic endotracheal disease.
And of course, the patient performance score.
Yeah.
Just tell me the early and late complications of YST.
So early complication would be one, patient didn't tolerate it on table at all, inability to track the stent, perforation while you're trying to do it. Late would be stent blockage, stent migration due to granulation tissue, and yeah, those are the ones that come to my mind.
Procedural bleeding. During the procedure, what about bleeding? How do you manage? While tracking you're going through the tumor, no? While tracking it.
Yes.
How are you managing aspiration, distal balloon or something? What is
we've not had terrible ballooning, but terrible bleeding in any of the cases that I have seen and been a part of. But in my understanding, if there's a lot of ballooning, we have the advantage of bronchoscopes. So we can do suctioning. If there's extensive bleeding, we can do a balloon tamponade. You can selectively put balloon in one lung which is bleeding and give selective ventilation to the other one.
Have you done it? Is it?
Pardon?
Are you doing it regularly? Are you needing it regularly is the question.
Are we needing it regularly? As in, you mean complication-wise?
The balloon distal ballooning or
tamponade? No, never. No. Thank you.
Thank you, Dr. Amreen. Next is Dr. Prabjyot Singh. Juries, please note it's OP20.
A very good morning to all. I am Dr. Prabjyot, and today I shall be presenting our retrospective analysis comparing the planned versus achieved ablation zones following percutaneous microwave ablation for liver lesions. So as you all are aware, microwave ablation is an integral component of locoregional therapy for primary and metastatic liver malignancies. And in routine practice, accurate pre-procedural planning relies on manufacturer-provided reference dimensions, which are typically derived from ex vivo or healthy animal models. However, real-world ablations are performed in perfused human livers, and there's heat sink, there's tissue heterogeneity and fibrosis, and all of these factors may ultimately influence the final ablation zone. Therefore, this study was conducted to compare the planned versus achieved ablation zones at 75 watts and 100 watt settings, and we examined whether discrepancies, if any, differed between the two wattage groups. So ours was a retrospective matched cohort study comparing prospectively accrued 75 watt microwave ablations with a retrospectively selected and matched 100 watt cohort. Now the two groups were matched for lesion location, the lesion size, the CTB score where applicable, and proximity to major vessels to minimize the confounding. All ablations were performed using the Emprint microwave ablation system, each lesion being treated with a single ablation, and in total 18 ablations were analyzed, 9 each in the 75 watt and the 100 watt groups. So as far as the measurements was concerned, the planned ablation dimensions were obtained from the manufacturer reference charts, whereas the achieved ablation length and width were measured on immediate post-procedural CT using multiplanar reconstruction along the axis of the insertion of the microwave antenna. And this is how we made the measurements by also ensuring that we excluded the zone of hyperemia on these immediate post-procedure images. And the percentage of discrepancy was calculated by subtracting the planned from the achieved zones divided by the planned dimensions and multiplying that by 100. So we focused on two primary metrics, the relative length error and the relative width error. And agreement between the planned and the achieved values was assessed using intra-class correlation coefficients and Bland-Altman analysis. And the differences between the 75 and 100 watt groups were evaluated using the Mann-Whitney U test. So this is a table summarizing the baseline characteristics of our study population, and as you can appreciate, both the groups were pretty uniform in terms of the patient age, the lesion size, the lesion type, the lesion location, as well as the proximity to major vessels. So this is the data of our 75 watt group, and this is a busy table, but what I want you to see is the percentage discrepancy that we got in the desired versus the achieved ablation length. And if you compare it with the discrepancy in the width, you can see that there's a stark difference between the two, with the discrepancy being significantly higher in the width as compared to the length of ablation zones. Same findings are also observed in the 100 watt table. So to analyze this data, we use two complementary methods. On the left is a scatter plot comparing the planned versus achieved measurements. The diagonal line that you see is the line of identity. So if the machine was 100% accurate, every dot would sit perfectly on that line. On the right is the Bland-Altman plot, and unlike a scatter plot, this gives you an objective measurement, and it tells you how much the machine is missing the target on a mean basis. So if you look at the length, the system is remarkably accurate, and you can see almost all of the dots are closely hugging the line of identity. And even on the Bland-Altman analysis, you can see that all of these dots are within 0.1 millimeters of the expected zone of ablation that we had planned. Therefore, it gets a very tight agreement between the two. However, when coming to the width, the results here are concerning and reveal a significant clinical problem. So every dot that you see below the line on the scatter plot represents a patient where we achieved less than what we planned, and that is 17 out of 18 patients. And the Bland-Altman analysis, again, you can see that there was a mean bias of almost 7 millimeters, stating that on an average, we were missing out on the width of ablation by approximately 7 millimeters. So that was the most major finding of the study that we found. And also the limits of agreement were pretty far wide, ranging from -1.41 to 0.5 centimeters, and with the maximum deficit of -1.4 centimeters, stating that there is a significantly higher risk of marginal recurrence in these patients. So finally, we used a box plot to see if power settings could mitigate this width effect. So while our p-value was 0.11, the visual trend is emphatic. You can see that at 75 watt, we see a median deviation of -25%, whereas at 100 watt, that error is reduced and the median comes down to 16%. So the relevance of this is that although both settings underperform, the higher wattage group appears to provide a more predictable, though still slightly undersized ablation volume compared to the 75 watts. So the crux of our results is the asymmetry of reliability with the Emprint microwave ablation systems, and a few studies have been published in literature, and this was one of them, again performed using the Emprint system. They evaluated 103 ablation zones, and their findings were pretty consistent with ours, where they found the transverse width to be the least predictable, and they also found out that 100 watt performs better than 75 watts. So while our study did not directly evaluate the causative factors of this discrepancy, established literature does suggest a few multifactorial biophysical etiology. So this discrepancy basically reflects the fundamental differences in the ablation physics. So ablation along the longitudinal axis is actually a product of the antenna engineering and is largely independent of the tissue environment. However, ablation along the transverse axis is actually a product of tissue factors. And these factors include tissue contraction that may be up to 15-25%. Then there are parenchymal discrepancies. Now the Emprint manufactured ablation charts that are available, they are based either on ex vivo bovine livers or they are based on in vivo healthy porcine livers. However, the human liver tumors, particularly in cirrhotics, they possess altered dielectric properties and increased stiffness, which thermally resist the outward conductive spread of microwaves. A third and an important reason is that there's vaporization. So rapid high power heating leads to tissue desiccation near the antenna, and this creates an insulating gas or a char sleeve that can limit further lateral energy transfer, a phenomenon more pronounced in the transverse plane than the longitudinal. Lastly, the thermal momentum comparing 100 watt versus 75 watts. So obviously the 100 watt gives you more thermal momentum and therefore can better overcome the local heat sink effects. However, even at 100 watts, the bias remains significant, likely due to rapid tissue desiccation around the probe, again creating that high vapor sleeve that limits further lateral energy transfer. So while our study is limited by its retrospective design, the limited sample size, the lack of subgroup analysis across tumor histology, its strengths lie in the inhuman assessment, the careful matching to control for perfusion-related confounders, a single platform analysis ensuring technical uniformity, and the use of appropriate agreement-based statistical methods. So to conclude, we found that achieved ablation widths were consistently smaller than manufacturer predicted values, whereas ablation lengths showed good concordance across wattages. Also, the trend towards greater discrepancy between the planned and achieved ablation zone width at lower power suggests a wattage-dependent variation in the in vivo performance, and therefore further validation in larger prospective cohorts is warranted to refine our predictive models, improve the procedural planning, and ensure adequate safety margins in microwave ablation.
Time's up.
Thank you very much. In the end, I'd like to acknowledge the entire IR team back at Medanta, Gurgaon, under the very able leadership of Dr. S.S. Pejal, sir. Thank you.
So the crux of it is that possibly the higher wattage is the better wattage.
Yes.
100 watt is the, which we consider the 80 watts is the sweet spot. It's not actually, it is the 100
Yes.
watt. And so to overcome the problem of the width discrepancy, what suggestions?
So suggestion would be to plan your ablation in a way where you're taking at least an extra 5 to 7 mm of margin. So the routinely, if you're taking just 5 mm, then considering the results of our study, we feel that maybe a further 5 to 7 mm of margin, especially along the width, along the transverse axis of the antenna, would give us better results. And that's how we've been doing it, which is why in all of these patients, even though the ablation zones were smaller than what we had planned, we had actually planned it in a way that was still exceeding the tumor margins by at least 1 centimeter.
So let's say your mean size was roughly about 2.3
2 centimeters, yes, sir.
Let's say 2.5 centimeters. So what ablation zone you want to create looking at your study?
So 3.5 along the perpendicular axis of the antenna.
Perpendicular to the
3.5
will be the ablation zone.
Yeah, 7 mm this side and at least 7
But I
mm.
think that will not.
So
that will
5
not.
plus 7, so 1.2 and 1.2 actually.
So you're saying 2.5 is the tumor diameter.
Yes, sir. So 7 mm here and 7 mm here.
But
1.9,
that,
so 3.9.
that isn't still we are not reaching the concept of A0 ablation of 1 centimeter.
So A0, whether we take it 5 mm or 1 centimeter, I think that's still debatable. Yes, preferably 1 would be the better ablation margin, but yeah.
So in usual, what you're planned is roughly about 5 millimeter margin when you plan the case?
Yeah, 5 millimeter, and we exceeded by almost 7 mm based on these results, especially if we are doing it at a lower wattage.
Okay, so you have in this study planned 5 millimeter on both sides in your study, and now you are recommending to increase to 7 mm, you are saying?
No, sir, since this was a retrospective analysis, we had, at the beginning, we had planned a larger ablation zone, which is why we didn't get the recurrences or the residual disease in these patients.
Right. So what I want to ask now, if you have to plan a 2.5 centimeter.
Yeah, now we would add the extra.
So what
yes.
what ablation zone you plan when you do the ablation now?
Yeah, so now we plan it with these results, keeping these in mind, and we plan for an additional 7 mm margin on both sides.
That means total
1.4.
Total width of the ablation.
Yeah.
Total width of the ablation, I am asking you.
Okay, so that will be the size of the lesion in the transverse plane plus 1.4.
1.4. So
yes.
let's say 4 centimeter.
Okay. So the maximum ablation it gives is 4.2, I think. Even if you keep 4.2 rating 100 into 10, I think we get a 3.5 centimeter ablation or something like that. So
Dr. Varun Yadav, please be ready. Dr. Payal Sharma, please be ready for the next. So we are back again to the schedule, the list we have, OP12, Esophageal stenting redefined.
Good afternoon, everyone. My topic is esophageal stenting redefined, expanding horizons with fluoroscopy guided approach. So, malignant esophageal obstruction causes severe dysphagia, malnutrition, and poor quality of life. Palliative stenting offers rapid relief of swallowing difficulty and improves nutritional intake in these patients. Also, it helps in closing down fistulas or leaks, which are commonly seen in advanced esophageal lesions, thus preventing and treating recurrent respiratory infections. Although endoscopic stenting is widely practiced, fluoroscopy guided approach provides comparable efficacy and several advantages, such as real-time visualization, reduced procedural time, and reduced need for general anesthesia or deep sedation. This makes it an ideal approach for these high-risk or debilitated patients. The purpose of our study was to assess the safety, efficacy, and quantitative improvement in quality of life following fluoroscopy-guided esophageal stenting. This is a retrospective observational study with a sample size of 19 patients who presented to our hospital in the past 2 years with malignant esophageal obstruction and underwent fluoroscopy-guided covered SEMS placement. All the palliative patients with severe dysphagia or esophageal fistulas or leaks were included in the study, and patients with incomplete records were excluded. All procedures were performed in the cath lab under fluoroscopy guidance. A nasogastric tube was inserted a day prior to the procedure, if not done already, and all lab parameters were checked and optimized. A single shot IV antibiotic was given, and either sedation or sometimes general anesthesia was administered before the procedure. So the patient was laid supine, and a shoulder bolster was placed to extend the neck. Their jaw was opened using a jaw retractor. The first part of the procedure was done under fluoroscopy guidance, where we gained access into the stomach via the stricture using catheter and hydrophilic guide combination, and after that we did esophagogram, and finally the stent was placed with the operator on the head end of the patient because that made the angles more convenient. So covered stents were placed under fluoroscopy guidance. Gentle balloon dilatation with large balloons were only performed when there was significant residual narrowing, and a continuous contrast flow across the stent confirmed unobstructed esophageal flow or closure of fistula. So let's go through a few cases. This is a 43-year-old gentleman who presented with dysphagia to solids, semi-solids, change in voice, productive cough. Upper GI showed mass at 20 centimeters with a fistula. However, probe could not be negotiated further. Cross-sectional imaging showed a large esophageal mass with adjacent cavity lung infection in the right upper lobe. So a palliative intent was decided, PAL chemo and esophageal stenting. So we did a gram ourselves, and to document and to know the site of the fistula. And once that was confirmed, we placed a stent such that it covered the fistula as well as the stricture at least 2 centimeter proximal as well as distal. And after stent opening, there was good flow across the stent with closure of the fistula. So post-procedurally, we would keep the nasogastric tubes for at least a day, and the feeds would go through the tube itself. The next day onwards, patient would be slowly encouraged to take food orally, first sips of water, then liquids, and gradually progress to semi-solid diet. And they were reviewed clinically after 1 week and 4 weeks. They were given these written instructions on how to go about with their life, with their dietary habits, to take soft and semi-solid diets accompanied with liquid, sodas, and avoid hard foods, chew their food well, avoid swallowing large chunks, etc. So technical success was defined as accurate stent deployment with immediate luminal patency. Clinical success was defined as improvement by at least 1 dysphagia grade and tolerance of semi-solid food. And complications were classified as per SIR guidelines. A quality of life was also assessed quantitatively using the WHO Quality of Life Brief Questionnaire, and symptoms such as dysphagia, reflux, cough, and pain were also evaluated both pre and post stenting. So let's see another case. Old gentleman, dysphagia. Again, this patient had fistula and severe infection of the right upper lobe. We could see the fistula itself on the gram. Usually I would advise not to push too much contrast. I'm showing this for the academic purpose, but we have stopped putting too much contrast now. And sometimes it is actually difficult to negotiate the wire into the true lumen. Many times it will go into the fistula itself, but with a few attempts we'll be able to get through these strictures because they are malignant, so they're not so hard to cross. So we measure the stricture length and place the stent size accordingly. So we can see that there was good clinical as well as radiological response in this patient. Another case of pulmonary esophageal fistula closed very well with the covered stent. So here the grade 3 dysphagia was treated very well, and the patient was able to take semi-solid foods after stenting. This is a case of lower esophageal growth with involvement of gastroesophageal junction. So here we placed anti-reflux stent, which has a mechanical valve at the distal end, which ensures fluid passage through in one direction only. So this is a case of esophageal pleural fistula, and here the stricture length was quite large. It was almost 10 centimeters. So we decided to go ahead with a 15 centimeter stent. We could not place it too much down because that would irritate the lower esophageal sphincter. So, however, there was on-table stent migration proximally. We tried to gently push it down using a balloon, but it was not going, so we left it as it is. And since the indication was to cover the fistula, we were not so worried about it, and actually there was good flow nonetheless. So, all of our patients were old age, 60 to 70 years. Majority of the lesions were in the middle third of esophagus. Almost 50% had fistulas, and 3 patients also had gastroesophageal junction involvement. Technical success was achieved in all patients except for 1 where the stricture could not be crossed, and clinical success was achieved in 15 patients. Minor complications, those seen in almost 1/3 of patients, were usually transient and resolved conservatively. We did not find any cases of restenosis or major events, although we lack long-term data because these patients are quite sick and they don't have a very long survival.
Time's up.
Just 1 minute, please, sir. Thank you. So we can see that there was significant improvement in the dysphagia score and significant improvement in symptoms such as reflux, chest cough, not so significant improvement in pain. And there was significant improvement again in the quality of life score, which increased by 10 points, almost 30% increase. Our study fared pretty well against previous studies in the literature with a technical success of almost 95%, clinical success of almost 80%, and a complication rate of 30%, but most of them were minor only. And our dysphagia improvement also compared well with the studies. So unique contribution of the study is that it gives a quantitative demonstration of improvement in the quality of life, which had not been done before as per our knowledge. There's few studies which have done it, have only done it qualitatively. The limitations are obviously the small sample size, the retrospective design, and the fact that we have only covered malignant cases. These are, I've just recapitulated the main points of our study, and I would like to conclude by saying that fluoroscopy-guided esophageal stenting is a safe, reproducible, and effective IR-based palliation care method for advanced esophageal disease. These are my references. Thank you.
What are the benefits over the endoscopic?
Sir, so we can completely see the procedure fluoroscopically. Real time, we can visualize the stent opening, the stent placement, we can be precise with it. Also, the procedure time is very less. This takes about 15 minutes. And we can, although if we are getting general anesthesia, we might have to take it as well, but we can also do it without general anesthesia, which might not be the case using endoscopy.
All endoscopic are done in the
no sir.
In the sedation.
They can also do under deep sedation.
So only see the classical benefit is that we are able to evaluate the distal part more clearly. Yes. Once we're crossing it. They just place it looking at the CT scan and regarding the clinical success of 78%. So that 22% includes whether the dysphagia has not improved or the fistula has was not.
So dysphagia has not improved. Fistula is closed in all the patients.
Yeah. Any precautions, especially for upper third?
Yes, sir, definitely, sir. So the major challenge you would find is when the lesions are quite high up, because you will have to open the proximal end quite close to the cricopharyngeal junction. Mark that area. We usually do that on CT on the same day or one day prior. We mark the area, and we also, if we have an anesthetist on site, and they are able to do a endoscope, laryngoscopy or something, they can give us the marking on fluoroscopy as well.
So usually if you have to see just on fluoroscopy, what your
yeah, so the usual markers would be don't go above C7. the cricopharynx is at C6, C7. Don't go above C7 because there is a parallax effect as well when you're looking at this patient on supine. If you think you have gone just above C7 and you get a CT scan, then it would be slightly higher.
Yeah, so C6 lower border,
yes.
definitely C7.
Yes, sir. So people usually come with the complaint of cough at the time of swallowing, which was their original complaint as well. Sometimes it is not resolved, and in some patients it is aggravated as well. If it is, usually we would put them on nebulization using Mucinex. If that is not helping and the symptom is too much to prevent them from swallowing, we would have to eventually place a nasogastric tube. No, on table. Usually they come on follow-up, ma'am, with these complaints. Thank you.
Thank you, Dr. Varun. Dr. Payal. Dr. Gopika is here. Not here. Okay. Dr. Abrar, your presentation next. Please be ready.
Good afternoon, everyone. I'm presenting a study from Tata Memorial Hospital, Mumbai, titled as Safety and Efficacy of Image-Guided Cryoablation in the Treatment of Unresectable Extra-Abdominal Desmoid Tumor. So a short rationale behind the study is that the desmoid tumor are mesenchymal tumor, and the treatment option we have is surgery. Surgery is usually morbid, and many times it is not possible. Second is chemotherapy, which is promising. Sorafenib and other agents are there, but same systemic side effects are more. And the third one is IR, interventional radiology. So the purpose of our study is to evaluate the efficacy and safety of image-guided cryoablation and to assess the local tumor control, pain control, and range of movement in the extremities and complications of the same. So method and material. So we included all the patients with fibromatosis, either recurring or residual after surgery or chemotherapy or hormonal therapy. And we excluded all those patients having a lesion in close proximity to the neurovascular bundle. So a total of 20 patients we took underwent 27 sessions of cryoablation. Our results are like, so a majority of our patients were in the age group 25 to 50 years old, and major complaints were pain and restricted movements. Majority of them, they had a surgery 1 or 2 sessions, and the location was lower limb. So we evaluated, on follow-up, we evaluated the response based on the RACIST criteria on contrast-enhanced MRI, and we got partial response in 80% of the cases, that is more than a 30% reduction in the tumor size. We evaluated the pain by using the visual analog scale. So the pre-procedural mean was 5, which reduced to 2.25 after 3 months, which is significant reduction in pain post-procedure. We evaluated the improvement in the range of movement by using the MSTS, that is Musculoskeletal Tumor Society score. Pre-procedural mean was 19.9, which increased to 23.7 post-procedure in 3 months. Increase in the score is a better outcome. In our cases, we got a reduction in the tumor volume for about 51 to 70%. So overall, there is significant improvement in the pain score at 3 months. The VAS was 5 to 2.5. The P-score was less than 0.05. And the mean MSTS was improved from 19.9 to 23.7 over 3 months. So here's a case of a 9-year-old child who underwent debulking of fibromatosis. So she had a large left gluteal fibromatosis. So in the post-contrast T1 weighted image, we can see there is intense enhancement of the lesion. The fourth image is showing ice ball formation, and the last image is of follow-up, which is showing significant reduction in the tumor enhancement, and there is significant necrosis centrally. The next case is of an 11-year-old boy with right gluteal fibromatosis. There is intense contrast enhancement. The cryoablation was done using cryoprobe, and the last image is just to show that there is some fluid density in the subcutaneous plane. We did hydrodissection. We do hydrodissection in cases where we think there is close proximity of a vital structure like a neurovascular bundle, or to protect the skin from burning. So we had one complication, which was transient neuropraxia of the lower limb. But that too was treated conservatively with steroids and physiotherapy, and the patient improved in 2 days. In conclusion, cryoablation is a safe and effective treatment modality in the treatment of fibromatosis, and it helps in pain palliation and improves the functional outcome in patients with extra-abdominal desmoid. Thank you. These are my references. Yes, ma'am. So basically, we did it for pain palliation and to improve the range of movement.
And then what are the chances of recurrence? And then
There are
later
chances
how
of, yes, ma'am. So there are chances of recurrence. We surely will call the patients on follow-up and assess.
and then redo the procedure.
Yes, if required.
So I think most of these are procedures not to get a complete
Yes,
ablation.
no cure,
These
yeah.
are this, so they will have the residual tumor.
Yes, sir,
The
correct.
main thing is the functional and the cosmetic
Yes, sir.
improvement, mostly functional and pain.
Ji, sir.
Right. So what is the usual reduction if of the tumor after cryoablation for desmoid tumor?
So
That
we
is
got, yes, sir. So we got a reduction, significant
maybe
reduction.
described in the literature also, you can tell.
Yes, sir. So we got a 50 to 75% reduction in 6 weeks. That's what we got.
And what are the benefits over thermal ablation, means heat ablation?
So basically, sir, for all the fibromatosis cases, desmoid tumor, we generally prefer cryoablation over thermal ablation because we take the patient in general anesthesia only, but we have seen that the bigger the ice ball is, the better the outcome is. So for in cases thermal ablation, we cannot ablate the whole entire area without causing any damage.
Okay. And so usually, let's say the tumors, how much time it takes for a procedure?
So yes, sir. So basically, it depends on system to system. So what the system we used to use was Boston Scientific. So generally, we take a bigger probe, which is a 14 gauge cryo probe, Ice Force, and generally it takes a 10 minutes freeze, thaw, freeze. So 10 minutes, 8 minutes, 10 minutes. So yes, for
So
one
roughly-
ablation.
So for roughly how much time all the cases you have shown? What is the roughly mean procedural time?
So 1 to 2 hours, sir.
2 hours. And how many electrodes you generally use for these?
So maximum we used in a case was 4 electrodes simultaneously. Thank you, sir.
Thank you, Dr. Payal. Next presenter will be Dr. Abrar. Please note OP15. OP15. We don't have the presenter for OP14, so we're moving ahead with OP15 by Dr. Abrar. Thank you.
Good morning, everybody. Today I'm here to present strategies for intraarterial chemotherapy in retinoblastoma and difficult anatomy. So IAC delivers high concentration of chemotherapeutic agent into the ophthalmic artery, so maximizing the local control while minimizing systemic exposure. It can be either primary, secondary, tandem, bridge or rescue depending on when it is given. So the goal here is globe salvage in retinoblastoma, but direct catheterization of ophthalmic artery is not always possible. It may be too small anatomical variants like ophthalmic originating from MMA may be there, or depending on the ophthalmic artery takeoff from ICA, catheterization may be difficult or they may undergo spasm. So this is a retrospective study which included 18 patients split equally between primary and secondary. Parameters assessed were technical approach, fluoro time, number of settings requiring enucleation or any side effects. So basic technique here, it is done under general anesthesia, 4 French femoral access is acquired, ICA angio is done, ophthalmic artery is identified, then it is cannulated with 017 neuromicro, then chemotherapy drug is infused. Most common drug regimen is Melphalan 5 mg and Topotecan 1 mg given over 30 minutes each. Triple drug therapy including carboplatin can be used, or high drug regimen can be used based on individual basis. Most preferred technique is the NOVA technique, where the microcatheter is advanced over the microwire beyond the ophthalmic origin, then microwire is retracted, then microcatheter is gently pulled back till it falls into the ophthalmic artery. This avoids spasm or dissection. Here is a fluoro video that shows the same. After which angio is obtained to see for choroidal blush and stable catheter position. So whenever this is not possible, we go for other techniques. First is wire cannulation of ophthalmic, then track the micro. Second is PCOM access. Then we have MMA access, utilizing the meningolacrimal branch. Then we have a balloon-assisted infusion, where a neuroballoon is inflated beyond the ophthalmic origin, which helps in flow distribution. Sorry. Yeah. Which helps in flow redistribution into the ophthalmic artery. It is jumping. So, okay. Come back on the one more. Yeah. So out of 18 patients, 30 sessions were performed. Average of 1.7 sessions per patient, maximum 4 sessions in a patient. So 21 patients underwent no wire technique. Wire cannulation had to be done in 6 patients. 2 patients MMA access was utilized. 1 patient PCOM access. So, okay. Depending on origin of ophthalmic artery, it can be classified as just arising from anterior genu, arising from genu and midpoint between genu and PCOM, arising from beyond this midpoint, arising from ECA, and arising from cavernous ICA. Okay. The types of regression patterns seen on follow-up are as shown here. 0 means there is no visible remnant, 1 is completely calcified, 2 is completely non-calcified, 3 is partially calcified remnant, 4 is an atrophic scar. 0, 1, 4 are considered to be good, 2 and 3 require more frequent follow-ups. So, no, there's a video there. Okay, fine. The image on the right is a image on the right here is a pre-IAC fundoscopic image showing the retinoblastoma. There's a video there that shows wire cannulation of the ophthalmic artery. This was the post cannulation angio showing stable position and choroidal blush. This below this image, this is the post IAC follow-up image showing type 1 regression complete calcification. So this is another case example of ophthalmic originating from ECA. Yeah. Okay. The image here is the pre-IAC fundoscopic image. This is the ECA angio, which showed ophthalmic artery originating from the accessory meningeal. This is the selective angio showing the choroidal blush and stable catheter position. This is the follow-up fundoscopic image showing type 3 central and type 4 peripheral regression. Okay. Sorry. This is another case example of PCOM access. There's supposed to be fundoscopic pre-IAC image. This is a diagrammatic representation showing the intended access through PCOM. This is the fluoro image showing PCOM access. This is the selective angio showing the choroidal blush and stable catheter position. This was type 3 regression on fundoscopy post IAC. This is the So this is ICA angio showing there's no ophthalmic or choroidal blush seen. This was the ECA angio which showed the choroidal blush, okay, which was arising from MMA. Then it was selectively catheterized. This angio taken which showed the choroidal blush and ophthalmic origin from MMA. So technical success here was described as successful catheterization and complete infusion, which was achieved in 100% of cases. So outcome was categorized based on the regression pattern. Out of the 9 primary, 6 had a good outcome, 3 had a poor outcome. Out of the 9 secondary, 5 had good outcome and 4 had poor outcome. So out of the 18 patients, 4 underwent enucleation, in which 3 were secondary and 1 was primary case. Mean time was 20 months from the procedure. Side effects that were seen were retinal detachment, forehead pigmentation, lid edema, vitreous hemorrhage, subretinal clot, retinal epithelial degeneration, occlusive vasculitis. So use of pre-procedure nasal vasoconstrictor usually reduces the nasal spread and systemic toxicity, and ice packs during the procedure helps in forehead erythema post-AC. So average time was 13.9, which was obviously increased during the PCOM and MMA access. Fluoro radiation dose was within 137 milligram. To conclude, it's a robust globe-preserving treatment. Pulsatile or intermittent delivery of the drug avoids reflux and breaks laminal flow. No other technique is preferred. When it's not possible, understanding the collateral pathway helps in technical success.
Time's up.
These are
you're not able to catheterize the ophthalmic artery, or there is a spasm immediately after that. So then, what is your flow of action? That I will do this.
First, we take the IC angio, make sure the ophthalmic artery and choroidal blush is there. We go ahead with no wire technique. If it's cannulated, we go ahead with the procedure. If it's not possible, next is and ophthalmic is originating from the ICA, we go ahead and try to cannulate it with the wire. But if the siphon is very tight or difficult anatomy or ophthalmic origin is very acute, then it's difficult to hook with the standard technique. If PCOM is good, we go ahead with PCOM access. But ICA angio is not showing any choroidal blush or ophthalmic artery is not visual, then we go ahead and see the EC angio. Then we see for choroidal blush, if it's visible and it's proper, then we'll take the access as the angio shows.
So when you use the flow diversion technique?
We haven't had to use the balloon assisted diversion. It's described in the literature.
Let's say if you have to use, what balloon you will use?
Any neuro balloon. The one described, it was Hyperform.
What is the global salvage rate of
salvage rate here was around 78%. Other articles also describe similar salvage rate around 60 to 70%. Outliers were in a study where they included more of secondary cases was very low to 30%, and one more study that showed very good result was around 90%.
So let's say the overall long-term prognosis of these patients. So let's say once you get the very good response, what happens in that? What is the natural history of the disease?
So these cases we usually get referred from a tertiary opthal center. So the data was coordinated between the
according to the literature, what is the natural history of the disease?
They follow 1 month follow-up. They do after every IAC session.
I'm saying you get the complete. So what are the long-term recurrence or anything? What is if you know about the literature?
Long-term recurrence, I'm not sure.
Okay.
Thank you, Dr. Abrar. Dr. Pooja. Dr. Mahendra, be ready for the next one.
Good morning all. I'm Pooja from Sri Chitra Trivandrum. I'll be presenting on a propensity match single center comparison between transradial and transfemoral access for TACE. So it's a relatively small project that we had done recently. So historically, though both transfemoral and transradial have been described for TACE, people have been more comfortable with transfemoral per se, since it's, that's what everyone's been trained with, and it's far easier to do, at least in the beginning. So transradial per se has been gained more popularity because it's more comfortable for the patient and the recovery times are faster for obvious reasons. However, it has been said to be associated with higher radiation doses. So we tend to, we want to check if that's actually true or not through our study. So these are the aims and objectives. So between transradial and transfemoral accesses, we have looked at these 4 parameters and how different they are in these 2 approaches. So for the uninitiated, so this is how we do the transfemoral and transradial access techniques in for TACE. So the methodology, it is a single center retrospective study done over a period of 4 months, and the parameters that were evaluated were in axis site complications, fluoroscopy time, dose area product, total fluoro and exposure dose area products, and what was the duration between initial puncture to the celiac artery cannulation, and what was the duration between celiac artery cannulation to the target hepatic artery branch cannulation. So through various literature, we have identified 4 major factors that are affecting radiation doses in TACE. So the patient-related factor being high body mass index and poor breath hold. Tumor-related factors such as multiple lesions being addressed in a single session or a very large tumor size more than 3 centimeter. Feeder-related factors where multiple feeders are addressed in one session or aberrant anatomy is present, and the use of CBCT, which is coming up nowadays. So overall, we have done propensity matching using 1:1 nearest neighbor matching. So, and these are the covariates that we have used to estimate the propensity score: age, gender, number of feeders addressed per session, presence of aberrant anatomy, and use of rolled scan, which is CBCT. So these are the demographic details, and the most common location of the lesion was in segment 8, and 20% had multiple feeders embolized per session, and 20% of the cases had aberrant anatomy. And these were the fluoroscopy time and DAP results overall. So the immediate technical success rate was around 100%, and yes, sir. The total fluoroscopy time, the mean was 1,951 seconds, and the total DAP was 23.57 milligram meter square, and the fluoroscopy DAP was 8.94. So there were no complications that were noted in those in the 60 cases that were evaluated based on matching, and the immediate success rate was 100. So these are the pre-matching results. So basically, there were over 80 cases that were done over these 4 months, 15 transfemoral and 13 transradial. And this is the pre-matching results, and you can see there was significant higher fluoroscopy DAP and in the transradial group, and the puncture to celiac cannulation time was also higher in the transradial group. So the interpretation being transfemoral, it is significantly faster when you from the puncture to the celiac cannulation, and the transradial approach had higher doses. However, after accounting for all the covariates, which is age, gender, number of feeders, the aberrant anatomy, CBCT, it has, the p-value has dropped, and overall an insignificant value has come. So thereby reiterating the fact that the actual difference that is said to be there between both the axes in terms of fluoroscopy time or radiation might not actually be due to the axis per se, and it could be due to various other covariates that exist, which have been identified in our study, and there are many others which still haven't been identified. So just to repeat the same thing, the p-value was lost after the matching, and in fact the absolute values between the transfemoral arm pre and post matching, that means within the 50 cases and the 30 cases, the absolute values in all the parameters remain pretty much unchanged. So the radiation dose, there is no significant difference after matching. However, the overall trends do lean towards faster celiac cannulation through transfemoral axis, obviously due to the shorter distance from the femoral to the celiac artery. And the transradial does tend to have a higher radiation trend, but however it's not significant. And in our study, we also found that there was faster cannulation of the segmental artery feeder on transradial approach. So these are the strengths and limitations of my study. Thank you.
So how do you, let's say retrospectively, you have seen this data, what were the actual factors that this patient should go for a transfemoral approach, or this, how it is done in the routine practice, not in the research setting?
So, in the routine practice, most patients nowadays we are preferring to do transradial approach. If after evaluating the proper radial artery anatomy, if it is favorable, we are preferring to do just for better patient comfort and even the access site complications are also since it is relatively better and the patient comfort especially. However, if there is improper anatomy is not good enough for the radial approach, there is severe atherosclerotic disease, then we are going for the transfemoral axis. And also patients who have this higher child score and they have lower platelet count and they are on any other antiplatelet drugs or for other comorbid conditions, we are preferring the transradial approach.
Right, so that is the most important limitation factor of your study, that the age and the atherosclerosis. So the data might not be in a retrospective study. It should be if you do it in the future, it's a good point to discuss. But well done study.
Thank you, sir.
Thank you, Dr. Pooja. Next, Dr. Mahendra. Dr. Apurva is here. Next is yours, Dr. Mahendra. Sir, OP17.
Good afternoon to everyone, and today's my topic is streamlining SIRT, an initial experience from the tertiary care centers, and that's an interim analysis. Usually the conventional CERT workflow, that's the patient seen in the IR clinic and the patient admitted for the mapping angiography, followed by the SIRT after 1 to 2 weeks. Here we do, in the first setup, we do mapping angiography followed by CBCT, and the MA injection was done and the patient sent to the SPECT-CT for LSF and TN calculations and the dosimetry calculations. But here in streamlined SIRT, here the patient comes to the IR clinic and we plan have mapping angiography plus the dosage injections at the same day and same setting with mapping angiography and CBCT volume calculations and the dosimetry calculation, the dose injections. What are our primary objectives? Objectives is to see for the feasibility to Y90 in a single session. Secondary objectives is to assess efficacy, safety, complications, and outcome. Materials and methods. So number of patients, we had a small number of patients, that's 8. It's basically a prospective single arm study. What are the inclusion criteria? That's basically it's a child age status of the patients, and within Milan and UCSF extended Milan criteria, patients were included. Exclusion criteria predominantly HCCs with PVTT and HVT, large intratumoral dysphormic vessels which leads to high LSF, and underlying lung issues with SpO2 less than 90, or ILD patients, or COPD patients, or patients with the prior TIPS were excluded. Study schemata here, the patient, the informed consent was taken, and the patient was explained about the procedures. The first mapping angio was done, and patient's CBCT was done, the perfused and tumoral volumes were calculated, and activity calculations were done. Here dosimetry, basically we followed a single compartment MIRD study, and the dosage we kept it to beyond the 250 gray planned dose, and LSF was assumed here to be less than 5%, and we used basically a 4-day pre-cal resin microspheres, and the Y90 was injected. The follow-up, clinical and imaging follow-up with the 3, 6, 9 and 12 months. The results predominantly in 2 subgroups. That's the patients within Milan, the 2 patients, the mean average size is to 4.5 centimeters, and the UCSF extended Milan criteria, we included 6 patients, that was mean size was 5.4 centimeters. Mean absorbed dose was 248 gray, and mean lung dose 2 gray under MIM software calculations. The outcome technical success achieved in all patients. Outcome for the follow-up of 6 months, no addition immunities was seen, and the complete response in 5 patients and partial response in 3 patients according to the MDCS criteria. Here, The first patient with NASH-related CLD with HCCs, here there was a hypervascular lesion in the segment 6, and the follow-up after 3 months, there was a complete resolution of the lesion, that is complete CR. Here the mean absorbed dose was 364 and D95 was 170 grays and lung dose was 0.1 gray. The next patient, he is also a NASH-related CLD with HCC. Here we had like ill-defined hypervascular lesion in the segment 3 of liver that was treated with a streamlined tear, and almost complete CR was attained after 3 months of MRA follow-up. Here the mean absorbed dose was 438 grays, D95 was 180 gray, and lung dose achieved was 4 grays. And the limitations. The study was we have a very small sample size and short follow-up period. To conclude, LSF is clinically negligible in patients with HCC with no vascular invasion or with no dysmorphic vessels. So when we plan for the segmental injections of MA, MA can be eliminated. Our initial experience with the streamlining trade using Y90 resin microspheres without procedural mapping, angiography, and lung shunt estimation demonstrates that it is feasible and safe treatment options for the selected patients with HCCs. So most of the evidence available is within the Milan's criteria. Our series highlight the fact that it can be done safely in larger tumor as well with the UCSF extended Milan's. Thank you.
So what is meant by mean absorbed dose? And if you're using the MIM software?
MIM software, sir.
So possibly you must be evaluating the dose given post-procedure also?
Sir. Post-procedure also.
So mean absorbed dose is, you are telling what has gone in the tumor along with the adjacent normal parenchyma in the perfused area?
In the perfused area, sir.
And
so we are taking the average of, because the tumor, most of the tumors were heterogeneous, so mean absorbed dose within the tumor as well as in the adjacent perfused areas.
So it must be giving the tumor absorbed dose also?
Tumor absorbed dose. It is basically mean tumor absorbed dose.
Mean tumor absorbed dose. Okay. Okay. So it means those patients who have no vascular invasion, dysmorphic vessels. So basically, there are some tumors possibly which are bigger than suggested criteria of streamline, that is small tumors if you are doing segmentomy, but you have done in few cases which are beyond segmentomy. So are there like 2 feet, what is the vessel means mean vessels catheterization and infusions? Are they most of the cases are single vessel infusion, or there were cases where there are 2 infusions?
So most of the patients who are single vessel infusion, single target artery, and very few cases are like 1 or 2.
Thank you.
Thank you, Dr. Mahendra. Dr. Apurva. OP18.
So my topic is vesical artery embolization for BK virus hemorrhagic cystitis post haploidentical hematopoietic stem cell transplantation. In hematopoietic stem cell transplant recipients, BK virus related hemorrhagic cystitis is a very well known complication, and it usually occurs about 30 to 90 days post transplant, and it leads to gross hematuria, prolonging hospital stay and transfusion dependence. BK virus causes urothelial inflammation and epithelial damage, causing diffuse mucosal ooze. And usually the conservative methods like bladder irrigation, antivirals, intravesical agents usually fail. And that's when vesicular artery embolization comes to rescue. It helps in achieving rapid hemorrhagic control, is minimally invasive, and is bladder preserving, and it avoids high-risk surgery in patients who are immunocompromised especially. Anatomical identification is the prime thing that is important. The vesical arteries are superior and inferior vesical arteries. Superior vesical artery supplies the superior part, including the dome and the superior surface, and the inferior one separate the bladder, but also sometimes supply the prostate and the seminal vesicles. Frequently, there's a common trunk, which is a superior and inferior vesical artery from where it arises, and basically the vesical artery arises from the proximal part of the anterior division of the internal iliac artery. This is a line diagram showing the right side internal iliac artery. This is the superior gluteal artery goes posteriorly, and then this is the anterior division. Usually the first branch that arises is the vesical artery. This is the diagram from the left side, the internal iliac artery, the superior gluteal artery goes, and then there is this is the anterior division of the internal iliac artery. This is the superior vesical artery. As I said, there can be a common trunk, the superior vesicle and the inferior vesicle. What we have to take care is that sometimes the prosthetic artery is arising from the proximal part of the superior vesical artery, which is a frequent occurrence. And in such cases, we have to ensure that we are going distal to this artery. So this is the angiographic image. Again, you can see here, this is the internal iliac artery, the posterior division and the anterior division. This is the superior vesical artery. As I said that sometimes there are common stump. This is the angiogram where we got a common stump, that there was a common vesical artery which was giving rise to superior vesical artery as well as the inferior vesical artery. The critical step, as I said, is the identification. Dyna-CT is the thing which is the go-to, where which would make by which we can actually ensure that we are in the right place. If it's not available, then blush and engorgement and tortuosity around the Foley's bulb. And what we do is we instill contrast in the urinary bladder to confirm that we are in the vesical artery. So in this image, you can see this is the Foley's bulb. We instill contrast in the urinary bladder. And then when we did an angiogram, we could clearly see that we are in the vesical artery. So coming to the study per se, in a span of 5 years, 15 patients underwent vesical artery embolization, age range being from 5 years to 45 years. Our youngest patient was 5 years of age, thus saying that age is not a limitation in this study. There were 9 males and 6 females. All the patients had undergone an haploidentical transplant, and cyclophosphamide had been used for preconditioning for immunosuppression. In all patients, the BK virus load was more than 10⁻⁷, that is a very high load, and all these patients also had thrombocytopenia and had failed conservative management. The average time after presentation was 41 days after transplant. Coming to the technique per se, transfemoral access was taken to cannulate the contralateral artery. We used a 5 French Cobra, and then for the ipsilateral, we used a SIM1. In both the cases, we could see the blush. In all the cases, we could see the blush, and superior vesical arteries were identified as using the same technique as I showed earlier in the images. Deep cannulation of bilateral vesical arteries was done. And embolization was done using 300 to 500 microns PVA particles followed by gel foam. Bilateral superior vesical arteries were cannulated in all cases. In 2 cases, we had a common trunk, and thus embolization was done for both the superior as well as the inferior vesical artery. Endpoint was considered as disappearance of vascular blush with marked slowing of the antegrade flow, and continuous bladder irrigation continued 48 hours post-procedure. In 1 patient, we did only unilateral embolization because it was a pediatric patient, and we had this fear of bladder necrosis in a pediatric patient, so we did a unilateral embolization. Again, these are the images. Pre-procedure, there was a blush, and then this is the post-procedure image. Same. Ultrasound images also, so this was the pre-procedure where the bladder was full of clots with the Foley's bulb in situ. This is an ultrasound 3 days post-procedure where there are no more clots, even though there is persistent bladder thickening, but when we put Doppler in this thickening, there is minimal blood flow or minimal color uptake. Technical success was achieved in 100% of the patient, and 11 patients showed complete response, that is 80%, which meant that post-procedure for consecutively 2 days, there was no macroscopic hematuria. Partial response we got in 4 patients, that is 20%, and partial response was defined as a decrease in the intensity of hematuria, but it not completely subsided. There was still some persistent macroscopic hematuria. Hematuria resolved within a median of 3 days post-procedure. None of these patients further required any sort of transfusion, and median hospital day was 5 days. Two of our patients did have transient pelvic pain post-procedure, but there was no other complication like bladder necrosis, rebleeding, or any sort of bladder contracture. Amongst the 4 patients that we had partial response, one patient was a pediatric patient, as I showed, where we did unilateral embolization. But in that patient also, after alum wash, there was a complete response. Again, another adult patient where there was a complete response post-alum wash. In another patient where we had actually embolized the common trunk, the superior as well as the inferior, but he continued to bleed. We had to do a right internal iliac artery coiling, the anterior division. And in patient 4, there was a graft failure with persistent pancytopenia. This patient continued to have macroscopic hematuria despite clinical success and technical success. So take-home message is that selective vesical artery embolization is effective and a bladder-preserving treatment option in patients who are not responding to medical management, and it can lead to marked improvement outcomes in BK virus hemorrhagic cystitis post-stem cell transplant. We achieved durable hemostasis in 80% of patients as a standalone procedure and nearly all patients with adjunct conservative measures. It reduced the transfusion need, prevented the need of major surgeries and morbidity, decreased the healthcare burden which is associated with BK virus cystitis. Thank you.
So, your second slide possibly said that the medical treatment fails most of the time.
Yes, sir.
So, do you recommend that being is as a secondary method, it should come as a possibly primary method who are significantly bleeding?
Sir, where the severity is relatively less, in such cases, we can still resort to conservative methods like bladder irrigation. But there are other methods which are described in the literature like intravascular, cidofovir, and all of that. I think vesical artery embolization is way superior to all those methods in terms of length of the treatment for which the chemotherapy has to be given, and the cost. The cost is also very high. So vesical artery embolization should be, in fact, should come before all these methods.
And what is the described recurrence rate after the bleed?
No, sir, there is no. So basically for BK virus per se, there is only one pediatric study which has been reported earlier in the literature of 26 patients. There is no rebleeding, and there is a study for unilateral versus bilateral where there is a significant difference. 60% curative after unilateral and 92% after bilateral. So we have chosen to do bilateral in all cases.
Thank you, Dr. Apurva. Next, we have a presentation from Dr. Anurag, OP63.
Let's now switch gears to a more benign topic. Good afternoon, everyone. The topic of today's presentation is percutaneous management of pediatric post-liver transplant biliary strictures, and we'll be looking at long-term results. After pediatric liver transplantation, biliary strictures can be seen in up to 1/3 of patients, and biliary strictures can contribute to graft loss if untreated. Various management strategies exist, and if anatomy allows and the expertise is available, ERCP should be considered as the initial modality. But in the setting of pediatric bilioenteric anastomosis and ERCP failures, PTBD is usually the go-to strategy. Sometimes we have to resort to non-anatomical biliary internalizations like hepaticogastrostomies and sharp recanalizations, and surgery is of course the last resort. We aim to analyze the long-term outcomes associated with percutaneous biliary stricture management strategy via PTBD. It was a single institution retrospective analysis of 24 pediatric LT patients between 2011 to 20 who were diagnosed with biliary strictures. The primary outcome was an optimal biliary outcome after 5 years of intervention, which was defined as graft survival with stricture resolution without recurrence and not requiring surgery. After a diagnosis established on ultrasound, MRCP in the setting of a strong clinical suspicion, we decided whether to do a PTBD or ERCP first, and if the PTBD was being planned, the ducts were punctured, internalized, and then a strictureplasty was carried out, followed by internal external drainage or rendezvous stenting. The patients were then put to a 3-monthly catheter exchange program for 12 months, and at the end of 13th month, a cholangiogram was done, followed by tube removal if deemed fit. Strictures were anastomotic. At the site of anastomotic, fibrotic healing caused by, first year was the most common time these were encountered and associated with bile leaks in most of the cases. Non-anastomotic strictures were 5 millimeters away from stenosis, from the anastomosis, and were multiple, longer. And risk factors included immunological, like recurrent sclerosing cholangitis, rejection, and vascular causes associated, like hepatic artery thrombosis. This was an example of acute on chronic rejection with a non-anastomotic stricture. So out of 410 pediatric LTs in this decade, biliary strictures were seen in 24 patients, and out of these, 17 underwent a PTBD, 13 as first line for HJ, and 4 patients as a bailout strategy after failed ERCP attempts, and a median follow-up of 10 years was there in the study. Out of our 17 patients, 3 had to be excluded from the long-term analysis, as 2 were lost to follow-up, and 1 PTBD was not internalized. And out of these 14, 12 completed the catheter exchange program. 1 patient died of sepsis once he traveled back to his country in Africa, and another patient required surgery after 3 months of initiating treatment because of chronic rejection. So out of these 12 patients, 75% or 9 patients had an optimal biliary outcome after 5 years. Let's look at the 3 unfavorable outcomes. 1 patient had a recurrent anastomotic stricture, which required a repeat PTBD. Ultimately, this patient had non-anastomotic strictures. And another patient developed portal biliopathy later on in the background of PVT and required a repeat PTBD. Another patient required a retransplant because of recurrent sclerosing cholangitis and eventually succumbed after the repeat transplant. So looking at the adverse outcomes, a recurrence rate was 1 out of 12 and was managed with the repeat PTBD. Disease progression was seen in 4 out of 14 patients due to non-anastomotic strictures, and deaths 2 as I just described. 10 patients had early strictures within 3 months, that is 60%, and a lot of them were associated with bile leaks. Looking at the survival rates, patient survival rate was 85.7% with 2 mortalities as previously described, and the graft survival rate was 78.6%. Another graft loss was due to chronic rejection, and this patient did well after a retransplant. The PTBD catheter duration was kept at 13 months. Some patients required prolonged catheters. Most of them were related to vascular complications like hepatic artery thrombosis or PVT-related portal biliopathy. Sometimes when we used a non-anatomic internalization, we would like to keep the catheters longer. Out of the vascular complications, 4 patients had them. 2 had hepatic artery thrombosis, out of which 1 developed a non-anastomotic stricture, which was managed with an additional PTBD. 2 patients had PVT, out of which 1 had portal biliopathy, again managed with PTBD. So predictors of poor outcome were actually related to a background pathology and not related to the procedure per se. Non-anastomotic strictures developing in the setting of an autoimmune sclerosing cholangitis, chronic rejection, sometimes associated with sepsis, and vascular complications created this scenario. Sometimes we resort to non-anatomical biliary internalizations. For example, this patient where the segment 2 catheter could not be internalized despite various attempts. So we attempted to do a sharp recanalization from segment 3 duct to the segment 2 duct in this fashion. This planning CT was done, and then the segment 2 catheter had a Dormia basket, and the segment 3 had a septal puncture needle, and this is how we punctured. And once internalization happened, we often use the retrievable covered metallic SEMS to widen out these non-anatomical tracts, and then converted to a rendezvous stenting and then catheter stent exchange program. Finally, everything removed after 18 months. Another one where we could not internalize the right posterior, just winding up. So we planned a hepatogastrostomy via percutaneous access, and this is how it was done. To conclude, PTBD is an effective rescue therapy in these patients, and favorable long-term outcomes have been seen. Successful cholangioplasty and internal external drainage can prevent the need for re-exploration. Thank you.
So, Anurag, how many cases? There were total
17
cases
with PTBD.
With PTBD, how many cases were duct to duct, and how much were HJ?
So duct to duct were 4, sir.
Duct to duct were 4.
Out of these patients, these were actually failed ERCP. After they did ERCP for anterior or posterior, and
so
one was left
13 were
out.
HJ and 4 were duct to duct.
Yeah.
So have you tried to evaluate that whether those unsuccessful cases, whether they were HJ or any correlation between?
No, sir. I did. First of all, the numbers are small. Secondly, the thing is that the ones with failed ERCPs, 2 out of those we had to do non-anatomical. Right. So anyhow, these will take longer. The catheter duration will be longer. However, both of them have done well, and the poor outcomes are only associated also in other studies also with the background pathology, sir. If there is rejection which is leading to non-anastomotic strictures, but for anastomotic strictures, the recurrence rates are low, and the success rates are to the tune of 80% as in our study.
So possibly non-anatomical corrections which were made, there were 3 patients?
2 patients,
2
sir.
patients.
2 out of these pediatric.
Roughly you can give the idea how much is the, you have follow-up of these 2 patients?
So 5 years, all of these are more than 5 years. One is 5, another one is I think 9 years
roughly,
now.
4 years tube-free, you can say.
Yeah.
Tube-free.
Yes, sir. Yes, sir.
And what was the mean age of these patients?
One of them was 8 years of age.
No, total 17 patients.
I haven't included it.
They are mostly small kids. So
Yeah.
managing these cases with internal external drain for a year is really tough. So have you ever thought of considering primarily placing a retrievable biliary stent in these cases, especially pediatric cases?
We have started moving to biodegradable stents for this, sir. But retrievable covered stents we did only for these 2 which were non-anatomical. But like you rightly said, sir, it is very difficult to manage catheters in such small kids, so we are moving to biodegradable stents. We have one planned for another patient planned for retrievable SEMS as well, but these patients are in the recent timeline, so I haven't included those because it was a long-term study. Thank you, sir.
Thank you all. We are done with the session. Thank you.
University of Pennsylvania and also numerous Children's Hospital. So we have a lot of time. We have 1.5 hours. And it's kind of basic. So I go literally slowly try to slowly to go through every aspect of the simple stuff. This is what we'll talk about: physiology, imaging, thoracic duct embolization, interstitial lymphatic embolization, chylothorax, chylosositis, liver lymphorrhea. And tomorrow I will talk about much more interesting. I have a half an hour, talk about kind of future, what in the pipeline, what we're doing already, and it's all around decompression of the lymphatic system, because at the end of the road, what's important is to decompress the lymphatic system, because that's 90% of the problems. So of course, this is Dr. Kopp loop micropuncture set. He started developing the first one, lymphatic interventions, thoracic duct, and this is my graduation. I look a little bit younger, it's 25 years ago. So 25 years ago, it's University of Pennsylvania does very fancy graduation party, like black tie, cigars and dancing and stuff like that at Four Seasons. So this is my graduation thing. So a few words I'll talk about the lymphatic system. So the idea of lymphatic system is take every fluid from the tissues and deliver it back to venous circulation. And of course, the process that moving fluid from the capillary into the tissue governed by Starling equation. Starling actually didn't write it. It's actually, the person who wrote it is actually somebody from University of Pennsylvania, Eugene Lansley. He just figured out and described it, right? But it's always balanced between oncotic and hydrostatic pressures inside the tissues and inside the vasculature. So, and what's super important to understand, and that's why it's our future, is that the lymphatic system is the only one that removes fluid from the tissues. So every time you have something that edema or collection of a fluid, actually it is a lymphatic system responsible. Heart failure, any ascites, pretty much 90% of the lymphatic system. Another important thing to understand that most of you already know that most of the lymphatic system actually deep inside your body. It's a liver, it's intestine, right? They generate approximately 90–80% of the flow in the thoracic duct. And flow in this system fluctuates significantly. If you have liver congestion, there will be enormous amount of flow coming from the liver. If you eat heavy food, it will be enormous amount of fluid coming from the intestine. So this is one of the oldest book from 70s, like huge book about lymphatics, because lymphatics in old days was very popular. So the lymphatic system, lymphatic fluid from different organs different, and that's super important to understand. Why? Because that's, by doing analysis of a fluid, we can figure out where's the fluid coming from. And we, at this moment, right now, we're using primarily three indication. It's triglycerides, of course, it's chyle, albumin, super important. Why? Because albumin, very predetermined. Next slide, I will show you. The concentration of the albumin in different limbs is different. And of course, cell count is differential. So usually in the blood, it's 20% lymphocytes. In lymph, it's 60 to 90, or you go by how much in the blood. If you have lymphopenic patient, you can say, oh, 3% lymphocytes is nothing, right? But then you look at the numbers in the blood, and it will be like 0.5%. Okay, that's actually lymphatic fluid. Same book. And the idea here is in thoracic duct, the highest concentration of albumin in the tissue, in the outside blood, is in the liver lymph. You kind of can classify where's the lymph coming from. Most of the time in chest, it will be chylothorax. Sometimes it's a liver lymphoria in chest can happen as well. Pelvis, groins, most of the time it is soft tissue. Abdomen depends where. Sometimes in the pelvis, most of the time in pelvis it will be soft tissue, a little bit higher will be chyle, and of course you have a disruption of the liver lymphatics, it will be a liver lymphoria. So this is short synopsis of all lymphatic pathology. Of course it's a simplification. Traumatic, not traumatic, right? For traumatic, we're talking about two things: transection, just cut the lymphatic vessels and they're leaking, but also obstruction. Surprisingly, we started to see more and more people that have obstruction of the lymphatic system, primarily thoracic duct, because of surgery. And when the moment you clean it up, the lymphatic system, and right now there's a new thing we're doing, we're actually using TPA to open the lymphatic vessels. It works amazingly well. So you can cure chylosasitis, chylothorax, and also lymphedema. And of course, radiation, there is not that much to do at this moment. We're still experimenting with TPA for radiation. We don't know yet. In non-traumatic, it's all starts with lymphatic obstruction. It's all about lymphatic obstruction that can cause either lymphatic leaks or organ edema. Abdominal edema, retroperitoneal edema, and so on and so on. We'll talk about that a little bit more tomorrow. So, of course, everything started with Scope when he actually figured out how to catheterize thoracic duct, and suddenly it's given stimulus to all of us to do something, because we actually can see the lymphatic system and actually can do something with that. And that's how us and others came with intranodal or interstitial lymphangiography. It's more common name, like it's intranodal lymphangiography, but it's a little bit confusion right now because different people are using different names. So, of course, intranodal lymphangiography is fluoroscopy, MR lymphangiography, and gadolinium and CT lymphangiography, water-soluble contrast. If you inject mesenteric lymph nodes, it will be mesenteric lymphangiography and liver lymphangiography. And of course, you can do a neck as well. So this is how it looks like. It's very simple. We, of course, using right now this hook needle that have a tiny hook that grab the lymph node. And it works very well. I'll tell you how and when. When you position your tip of the needle, actually, we originally said in the cortex, right, or transition. No, you have to go to the hilum. And when you do this, access the lymph node, you actually feel this resistance. And the moment you go to this resistant point, you know you are perfectly there. But you have to be very careful, because if you pass the resistant point, you just pass the hilum, and it wouldn't be good. Of course, watch for lymphovenous connection, because you don't want to inject Lapidol into veins. How do you deal with that? You can reposition in the same lymph node, or sometimes access with different lymph node, or sometimes there is no. Some people have totally obstructed, and any lymph nodes you access, they will be leaking. So this is how it looks like on ultrasound. So you see this white stuff here. Needle comes, touches the cortex. We look left, right, left, medial, lateral. Okay, we're in the center, and then I advanced a little bit into this white stuff, right, and deploy the hook. And of course, here is the lymphangiography. And this is a hook needle. Again, it's become indisposable in my practice, but people like it. Right now, there's almost 70 hospitals in the country using that. A lot of time, you actually, instead of injecting the Lapidol by hand, we attach it to the syringes and inject.
Hi, this is our preparation for the intranodal lymphangiography. At this moment, we use it with this needle. It's a spinal 25 gauge needle connected to this connector. This is very important because during the lymphangiography, we would like to switch different contrast. So this allowed us to switch your contrast with the needle. Then we have 3 syringes, and I like to color code that. Yellow for the oil-based contrast, Lapidol, blue for the water-soluble contrast, and white for saline. And here we have Lapidol, contrast, saline, and the 4th cap is actually for the methylene blue, because when we're going to do procedure and the surgeons open the neck, one of the ways to identify the thoracic duct is by us injecting this saline. So here we go. We take a little Lapidol right now into yellow syringe, connect it to the needle, and flush it, of course, and we'll go to do the lymphangiography.
So how do we speed up, the most important thing, how do you speed up the propagation of contrast? There's 4 techniques, and actually number 5 came in. First, lymphatic compression on calves. We did study, we showed it's better. Saline flush. So remember we had this syringe with water, saline. So I used it a lot. I actually use saline as a contrast, negative contrast Lapidol. So you feel the lymph node and Lapidol stuck there. You access the lymph node with the saline and flush it out. And if you position well, you can again add more contrast. So this is the number 3, axis of upstream pelvic and abdominal lymph node. And Ajit Yadav actually came with the idea of hitting Lapidol. We use it. It has to be official study to show it's working, but we definitely use it. This is the cuffs, of course. It's what we use. We actually use the alternative compression device for DVT, and it's worked for us. It's cheap. So this is how, let's say, lymphatic Lapidol feel the lymphatic system, and everything kind of stuck here, and nothing goes. What we're going to do, inject saline and propagate it further. Just be prepared if you do it under local under moderate sedation. Saline is very painful, so I will inject a little bit lidocaine before. So this is the same thing here. You can see that we flush the Lapidol with the saline. So here, nothing goes forward. Everything stops. So what we can do, we can access this lymph node under fluoroscopy, position it nicely, and then inject saline. And look at that. We actually can flush Lapidol all the way up. You can see it well, right? Everything. Do you think we can dim the lights here somehow? So you can flush Lapidol, and after we flush Lapidol, in the perfect position. Okay, let's inject Rapidol or contrast, and this is next lymph node will be here apicified, and you can access that. This technique I use every case. Because of doing all these combinations, we actually can reduce the time from lymph node injection until we get the thoracic duct for like 10-15 minutes. I don't have any patients. And of course, for this retroperitoneal pelvic lymph nodes, you can use hook needle is very valuable because it stays there and just you keep injecting and injecting. Here's a new technique using the hook needle. We actually figure out that we can do regular contrast. If you inject very, very hard, I'm not sure how much you see that. Do you see the thoracic duct? This is like 2 minutes after inject lymph node. Systemically, sorry, here. Oh, you don't see my, actually you don't see my, oh, hold on, you don't see my, okay, here we go. I thought that so you see here? This is actually thoracic duct, systemically. Ah, interesting, I actually could not, I probably have to, I can do it there. Yeah, so this is systemically. So, and then what you do, so again, you can see it here, very faintly. Sure? That's just my imagination. Of course, I see it much better. So you can see it. So what's the beauty of this technique? First, it's very short, right? You inject, pressurize, inject contrast, of course, 300, 370, and inject as hard as you can. You can access the upper lymph node and inject more. And then this contrast fills the whole systemically. Because when you use Lapidol and the flow is very fast, you only see like kind of bubbles going through. Here you can see the whole systemically. It's only for 30, 40 seconds, but it's enough time for you to get access to that. We did 15 cases like that, and it works magic. And actually, there's even more other advantages that I just don't have to talk, don't have time to talk today about. So next, oh, here we go. Sorry. So of course, this is just a diagram where you can inject the lymph nodes. Anywhere you can have them. Mesenteric, definitely. Intranodal neck lymph nodes, axial lymph nodes, if you can find. Popliteal, very, very hard to find. And of course, liver, right? Liver lymphangiography. So also, this is a diagram to show you the relationship. So you have a chyle that comes here and hooked up to the retroperitoneal lymphatics and continues in systemically. So this is where all the chylous pathway going through, right? So that's a reason, if you, and I will talk about that later, if you have a rupture or something here, you do intranodal lymphangiography, you're not going to see any leak. Intranodal lymphangiography will be absolutely normal. Sometimes liver lymphatics hooked up somewhere here to the mesenteric. So you can do from liver lymphatics show mesenteric lymphatics, it's possible. So that's the reason when we have difficult cases, such as callus ascites, not traumatic, we inject everywhere. And something communicate with something, but primarily mesenteric lymphatics for callus ascites. So again, another schema of what different lymphatic imaging we have. We right now have more lymphatic images. I will show it tomorrow. Something you can actually drink and actually can absorb in your intestine and see thoracic duct. It's called it's PET scanning technique, 18 FTHA, but also got a lot of money for government, developed the same thing for CT and MRI. And we're already working very hard. Actually, the first rat will be injected when they wake up tomorrow, wake up on Thursday in the US. So with the first experiment was the first things will be done tomorrow. So this is MRI. This is always show the same slide because they're kind of nice. On the left, and by the way, interrupt me, ask question in the middle. If something not clear, we have plenty of time. So you can see thoracic duct kind of normal on the left side. Obviously, we missed the injection on the here. This is CT lymphangiography, one of our first cases. I don't use it, CT lymphangiography, because MRI already well established, number one. Number two, we get feeling that sometimes a CT lymphangiography is not as precise as MRI. Contrast doesn't go to the periphery, but a lot of people in the world using CT lymphangiography and treating based on that. So, and of course, this is abnormal. You can see here is thoracic duct have this flow into the mediastinum. This is a patient with plastic bronchitis, and here's clearly something abnormal. There's two things going on here. Number one, there's a lot of lymphatic production. That's the reason why it's such a dilated thoracic duct. Some people have it. This is one of the pathophysiological mechanisms. Some people generate enormous amount of lymph out of nowhere. Definitely 100% Noonan and most of it down. Costello syndrome have a very, very brisk lymphatic flow. And that's one of the reasons why Noonan patients has so much lymphatic problems, right? Because imagine yourself, you have a huge river going, and you have some kind of blockage accidentally happen, and then you have a leaks, collaterals, protein losing enteropathy, edema, chyluria, scrotal lymphoria, calothorax, what you name it, because there's enormous amount of lymphatic flow in the system of Noonan patients. So MRI, generally we have two techniques, T2 imaging and contrast injection. And of course, we inject contrast into the growing lymph nodes in these cases. And both these techniques are kind of complementary. So we do injection through the injector, and this is our kind of poor man setup to do that. And this is how it looks like on a real patient. This is our injection rate. We never optimize that. We don't know if it's right or not. We just started doing it. It's kind of working, so let's go with that. We probably at some point need to optimize it better. Why T2 imaging is important? Two reasons. You can see fluids, you can see edema, you can see masses that you don't see with contrast injection, because sometimes the mass is outside the pathway of the contrast. This is an example, of course, masses on T2 imaging and of this pleural effusion. This is another example of mediastinal masses. You can see tortuous thoracic duct that tell you that there is something going on with lymphatic system, some type of obstruction. You can actually see collaterals develop, again, sign of a lymphatic obstruction, and for rare diseases, you go to the bone lesions. But here's an example of why we use it. This is a lady that developed horrible abdominal pain, and it's, by the way, we started to see more and more patients. We didn't advertise it yet because we're afraid that all country come to us if we say, oh, we can treat abdominal pain, here we go. So two of my daughters have candidates for my procedures, I think. So it's such a common disease. So this is our first ever we done. So we did T2 imaging, and we can see here, and during that time we actually didn't realize it, this is actually very dilated thoracic duct, and you can clearly see that. But on imaging, you don't see it at all. Why? Oh, because, and this is lymphangiography, you can see that slowly, contrast propagate until we see the obstruction of the thoracic duct. And that's the reason we don't see it, because the contrast, that when we inject groins, it just doesn't go there. And of course, we see this nice clot. And during the time, we didn't know what to do about this clot. Right now, we do it a bit different. I pushed it somehow with my wire, because I didn't expect to see it. Like it was 7, 8 years ago. So, and since then, she's asymptomatic 7 years. She doesn't have any abdominal pain. Before that, she was going to emergency room twice a week, twice a month. And you can see here, this is your clot and thoracic duct. After opening totally and ask you to cough, just to clean it up more, and it's working very well. So this is actually the first time I ever saw clot in lymphatic system, and right now we see it more and more. Liver lymphangiography. So when we do liver lymphangiography, you actually, your target is white stuff around portal vein. What is white stuff? It's dilated lymphatics. And so every time you read, or your colleagues read CT or ultrasound, MRI, and say, oh, there's a periportal thickening. It's actually dilation of the lymphatics. The same goes with gallbladder. Right? If I don't have these images here, but a lot of time you do liver lymphangiography, you actually can feel with your contrast from the peripheral lymphatics gallbladder. So every time you have, edema, like heart failure and gallbladder thickening, that's dilation of the liver lymphatics, gallbladder lymphatics. So this is one of our cases. So you can see here, we put a needle inside, and you clearly can see leakage of the contrast into the duodenum. Right? So when do we use liver lymphangiography? Liver lymphoria, it could be traumatic and not traumatic. We actually started to see a patient, we only have a 5, with ascites in horrible heart failure, in okay heart failure. So patient actually normal ejection fraction with some a little bit elevated, some valve replacement, horrible ascites. We do liver lymphangiography, and we actually can block lymphatics, and they're cured. We just submitted a paper about that. Protein-using enteropathy, of course, that's how we started our journey with protein-using enteropathy. We still use it. Callus ascites, for sure, it's another entry point. And in some cases, there's a plastic bronchitis. We published a few papers about that, where you actually do liver lymphangiography and see lymphatics shooting into the mediastinum. And I'm absolutely guaranteed there's some patient that will have pleural effusion because of the communication between liver lymphatics from the falciform, not falciform ligament, falciform ligament into the mediastinum. Because we saw plastic bronchitis, we have almost 10 or 11 cases, primarily children. We have 2 adults right now. So, of course, when we develop this new liver lymphatic imaging agent where you inject IV, like a HIDA, lymphatic HIDA, right? You inject IV, then we'll figure out, okay? Mesenteric lymphangiography is super important. Been done for many, many years by a lot of people in OR, and kind of obscure papers were out there, but eventually Sabion Hoor and his team performed this intraoperative mesenteric lymphangiography, and then we started to do percutaneous one. And we published paper about that, and not referenced with Sabion approximately 6 months ago, and we designed different classification of mesenteric. Useful, definitely useful technique, not for everybody, but definitely protein-losing enteropathy and callus ascites. So here you can see we inject lymph node percutaneously, and here you can see the contrast leaking into the duodenum. Of course, this is a patient of protein-losing enteropathy. For mesenteric lymphangiography, these needles are must, because it's almost impossible to put needle without sliding out in a second, so it's actually a lifesaver for us, for sure. So where have been before we developed all this lymphatic imaging? That's what we've been. Like, that's our diseases. Lymphedema, of course, everybody knows lymphedema. Lymphatic leaks, Kyle, right? Lymphatic malformation. Pulmonary lymphatic disorders, why? Because biopsy. Somebody biopsy lymphatic tissue lung and see the lymphatic tissue here as pulmonary. And protein-losing enteropathy for the same reason. So right now, that's where we're standing. We already started to discover more and more diseases, understood pathophysiology of a lot of diseases. Kylura, it was mystery disease for everybody. And right now, we know it quite well. So I will try to apparently, there's a lot of Kylura patients in India, right? So tomorrow I'll try and put a few slides about how to treat Kylura. It's actually not bug-related, not bug, parasite related, because I actually never done one. We always have ones that spontaneous because of obstruction of the thoracic duct. So maybe it's totally different. I don't have any experience with that. Of course, all pulmonary lymphatic disorders, callus ascites, we understand much better what's going on. Protein-losing enteropathy, genital lymphoria. This is super important one, chronic acute abdominal pain. We published paper in radiology, but we actually never advertised that, and were very, very careful about that because we didn't have a drink. So right now, of course, this patient was chronic and acute abdominal pain. I will talk about it tomorrow. They have obstruction of the thoracic duct. So but it's very hard to understand who is obstructed. So the moment we'll have this drink where it absorbs clinically for everybody, so then we'll do clinical trial with imaging of the lymphatic system. This is a big one right now for me. Become abdominal and lower extremity edema. We started to see more and more patients. We figure out different ways to decompress them. I will talk about tomorrow. And liver lymphoria ascites and many more diseases. So, any question about imaging? So we will move to procedure. So there's a 3 group of the procedures: classical thoracic duct embolization, interstitial lymphatic embolization when we inject tissues with glue. And this one, we'll talk about that tomorrow because it's future. We'll all be doing a decompression of thoracic duct in 3-4 years from now. At least I hope so. So thoracic duct embolization, 2 main indications: callothorax, plastic bronchitis. Right? Plastic bronchitis is quite common in the US, but still underdiagnosed condition. Right now we published, supposed to publish in the radiology, it's already a second review paper. It was 80 plastic bronchitis patients. 100% of this patient came to us after self-referred and after at least 5, 6, 7 years constantly coughing and nobody diagnosed them. So hopefully with our big paper and this we try to advertise, get into the heads of pulmonologists that it's a real condition. And I'm sure there's a lot of patients in India, 1.4 million people, right? Thoracic duct embolization. Start with intranodal lymphangiography. We talked about that, thoracic duct access and thoracic duct embolization. So, of course, you can go through everything. the only thing I would say, don't go for maybe gallbladder, because I heard some people told me that there was a complication when they rupture gallbladder, but usually gallbladder is not on the way, and I'm kind of careful not to hit it. Pretty much the technique is.
So we know approximately where the cisterna cali starts. So what I'm going to do right now, I'm going to mark with hemostat the entry point in the skin. It's approximately 3, 4, 5 centimeters from the where we're supposed to stick the cisterna cali. Depends, of course, how big a patient is. Smaller patient will be less. And we start to advance needle until we hit the spine, because cisterna cali sits on spine. Hopefully we'll penetrate through and through. When we advance the needle, we advance it and hit the spine with BL up, then we rotate the needle this way so the wire can go in the cranial direction. So I started to slowly pull needle back. Okay, I am to the left of the cisterna cali thoracic duct, so I put my needle, relocate it, and stick it a bit more to the left, rotate it up, and slowly start pulling the needle while advancing the wire. No, here we go. We are lucky today.
So of course you don't see cisterna cali. Why? Because I already saw it, the contrast, the bubbles coming through, right? So I know exactly, because I'm perpendicular to that, and the cisterna cali sits between the IVC and aorta. I just boom, going down, right? So because flow is sometimes so fast in the cisterna cali, you could not see that. Why is it so fast? Because when you start doing your lymphangiography, the contrast slowly creep up, and still start to fly, because liver and intestine lymphatics kicks in and start to flush everything out. So how do we deal with that? So this is one technique, the double needle. So you put a needle above cisterna cali, compress it kind of thing, and then with second needle, after contrast accumulate, you can advance it. Okay. However, Dr. Keong from Vietnam said, oh, I don't do needle, I inject saline. And here we go. You can see here, I put first needle here and inject 20 cc of saline next to the thoracic duct. So it's a temporary obstructed thoracic duct, and immediately started to see accumulation of the accumulation of contrast below the needle. And then you can you have a target, so it's easy. It's become easy. And here's, again, it's kind of, I'm pushing it a bit away, but eventually you can see I'm slowly started to pull back needle and advance my wire until wire goes through. It's a very, very, very useful technique. I use it almost every time. Because it's just, unless you see like beautiful cisterna cali. And all my fellows right now have one stick cisterna cali. If you put a needle against, close to the thoracic duct and infiltrate like 20, 30 cc of saline, it's not a problem at all. So thank you, Dr. Keong. So after you put the catheter, there's some technique how to put the catheter, but for some reasons, during the course we train this technique, but you can see here I inject contrast, and I don't know why it's not working, but you can see there's the reflux, there's obstruction of the thoracic duct and reflux of the contrast inside the lung parenchyma. This is how it looks in the patient. There is a special needle we developed to access thoracic duct. I am not happy about that needle. The engineers right now are redoing it, totally redoing it, and hopefully will come with a much better needle. Probably I will, at the end of the month, I'll really try a few examples. You can totally embolize thoracic, 0.14 wire. So we'll have, I use transient wire. It's a problem because it's like 30 centimeters. So we actually came with a new wire for thoracic duct that's very similar to transient. It's just very, very floppy, short floppy, like 10 centimeters, and it's a good wire. We love it. It works amazingly well. But it's not even in the US available. I think it will be in 2-3 months. You can do embolization of the thoracic duct totally, or you can act selectively and embolize this branch. So sometimes you can embolize easy thoracic duct in normal people. You have to be careful embolizing thoracic duct in heart failure kids, because they can develop protein-releasing enteropathy. We still don't know, but better not to embolize. So we're trying to do more selective, but one of the interesting techniques what they're using is that in order to, when you inject your glue, in order to glue propagate further, but not reflux in thoracic duct, we actually put a second catheter, and while we're injecting glue, we're actually injecting D5 and pressurizing thoracic duct so glue doesn't reflux into the thoracic duct. So other than that, you do thoracic duct embolization with coils, just 014 or 018 regular coils. Why we need coils? Because the glue interacts completely different with lymph than the blood. And Klaus Pieper from Germany did multiple experiments, shows that polymerization is much slower than in blood. So if you inject glue and continue to pressurize it, it will go and go flow into the vein. Why? Because the core of the glue cast liquid. So it's like lava, right? You inject and it's continue to break and go and flow. So coils primarily to break, give like something to glue to grab. And this is another glue injection. So this is another important thing. So you see, if I inject too hard, it's actually going through. So what's the technique? Number one, dilution 1:1. Don't do 1:3, not to 1:2, 1:1, because you have plenty of time. And number two, when you flush with D5, you flush just a little bit. You literally create distance, separate the saline from the glue. Because if you flush the whole thoracic duct with D5, no glue going to polymerize. It's just, there will be no ions there. So number one. Number two, the technique is you inject glue, wait until they hit the coils, then you pull back a little bit, wait another 3-4 seconds, inject contrast, if it's contrast glue. If it continues to flow, wait. If it's not refluxing back, you're pretty much done. You pull back a little bit, inject a bit more, and that's it. Most of the time, you don't need more than half cc of glue to embolize total thoracic duct. Is it safe? Absolutely. We submitted to GVR second paper for long-term follow-up. First paper was 14% complication rate, primarily because of pedal lymphangiography. Because pedal lymphangiography causes people lymphedema. The moment we switch to intranodal, no complication of lower extremity edema, but also no pretty much almost 100%, even 12 years I've been doing that, 13 years after the embolization is no issues at all. So outcomes of traumatic calothorax are very good. So this is a study we published, my partner published it, and it's kind of like funny. So there's two different groups, one with pressure cuffs, the other one with no pressure cuffs. I don't know, he wanted to be original. I don't know why he did it. He didn't ask me. Anyhow, in both cases, our success rate is very high, more than 90%. And of course, when you put a pressure cuff and increase the flow of the lymphatic system, your procedure time reduces significant. It's statistically significant reduction. So non-traumatic calothorax. For years, it was super difficult for us to understand until we figure out. And right now we know everything about, not almost everything. Like we have 1 or 2 cases recently that we're struggling and understanding. But pretty much non-traumatic is very simple. Most of the causes what we see, idiopathic. Why people develop calothorax? Because they're obstructed of the thoracic duct. Why they're obstructed thoracic duct? We don't know, but it's clearly, it could be surgery, it could be trauma, it could be COVID, it could be out of nowhere. Like wake up one day, suddenly you have calothorax. So what do you have? You have abnormal lymphatic anatomy. You have like, instead of one thoracic duct, your thoracic duct with multiple branches. And you can live your normal life until the thoracic duct clogged. That's where we started, not for calothorax yet. We have, in one case, we started to use TPA to clean up lymphatic system and bring it to the native state. But also you can, most of the time you will see, we actually embolize it. Sometimes lymphoma. Lymphoma can compress lymphatics and cause, again, this reflux and leakage. How we diagnose that? We start with MRI. Of course, always we start with MRI. And we're looking for number one, ascites. Most of the patients I personally get right now is actually callous ascites present as calothorax. Super important because if you have callous ascites and you embolize thoracic duct, you make things 1,000 times worse. And we saw cases coming to us from other places, that people just, or surgeons like, oh yeah, calothoracx, let's ligate thoracic duct. No, it was callozysitis. And it's just holes in diaphragm. The other two causes, the abnormal flow from thoracic duct to the lung. And the third one, also very important, communication between retroperitoneal and mediastinal lymphatics. Again, if you miss this part and embolize thoracic duct, they make things worse because you redirect your flow directly where the leak is. Again, it's all about obstruction, and actually callozysitis is also obstruction. I just kind of, didn't include it here most of the time. So again, this is a message, very, very important. Don't embolize thoracic duct in presence of asthmatis. So when you say, oh, this patient doesn't have ascites, because our first question, calothorax, does the patient have ascites? No, he doesn't have ascites, just a little bit. That's it, that's enough. Literally few drops between the intestinal loops, it could be it, because the mechanism of sucking fluid from the abdomen is very, very good. So it actually can dry your abdomen. And what you do, in the past we used to inject, like put a needle into peritoneal cavity, inject some nuclear medicine stuff. We stopped doing that. We just sample fluid from both places, right? And if it's similar, it's a callozysitis present as calothorax. It's probably like 78% of the cases I'm doing right now. And so how do you compare fluids? Can you do triglycerides? Yeah, you can do, but let's say a patient ate today and yesterday he didn't eat and will be a little bit elevated but different. Can you do cell count? Yes, but it will be a little bit different. But albumin will be exactly the same. Nothing changed in albumin. No diet, nothing. It will be exactly the same albumin. So that's the reason we use albumin as one of our main thing, right? And of course, when you do, on this patient, you do MRI, usually you don't see this abnormal lymphatics going anywhere. So this is just an example of the...
We're taking right now. Yep, saw that, yep.
Okay. I'm sorry, I'm not sure why is it going like that. It was not. So the idea is there is that you can see holes and Kyle going, and you look at the diaphragm right now from a surgeon perspective, from thoracic surgeon.
We're taking right.
So then abnormal form of thoracic duct, you can see it here. Sorry, it's supposed to be like a joke, but hold on, let me do it. So I'm not sure it's not working. Anyhow, this is abnormal flow, and it's actually a dog. So dogs actually have a lot of calothorax. We treat a lot of dogs right now. It's my partner moved to that. This is our first dog. We actually have a cat. Cats also with calothorax. We actually have Jeff Geschwin cat with callozysitis. So we have a big business in veterinary medicine, right? So surprisingly, actually, it's a very, very developed field in veterinary medicine. We actually trained first 25 years first to surgeons. And one of them, he's the head of, like, he's Chick Weiss, every SIR he'll come. And somebody will make a joke, oh, you put gastrostomy for the dog. It's like, I'm here, by the way. So Chick Weiss, he has a better suite than you have in New York. It's called Animal Hospital. That's the name, Animal Hospital, something like that. American Medical Hospital. So it's a 7 floors building with a radiation unit, huge radiation in the basement. His IR room has a CT, ultrasound, and endoscopy all built in. Everything comes in, right? So, of course, there's a Kissinger. He's on board, and everybody on board of all these famous New York people with their pets. Anyhow, it works very well. We didn't publish a paper. My partner took over. We did 50, 60 dogs by now, probably. But this is a real patient. Right? And the idea here is, of course, super fast lymphatic flow. This is a normal guy, just from Texas. I remember well. He lives his normal life, no problems. And suddenly he has calothorax. Why? He has, that's many years ago, he always has abnormal lymphatics, enormous lymphatic flow, and something happened. Somehow he blocked his lymphatic system, clot, and right now he's leaking. Okay? And it's the different variation of this lymphatic flow. This is another example, and you can see even when we inject thoracic duct, obviously it's kind of like a fusiform, but at the end of the road, you can see it here leaking inside the mediastinum. Just another example. So this is easier. You go selectively, non-selective, close thoracic duct, no problems at all. Then you have this situation. This is a patient that has a retroperitoneal to mediastinal connections. And this is another one. So you can embolize thoracic duct because flow also comes from the thoracic duct, but you wouldn't cure the problem because the leak is here. So what you do, you put a needle in the these masses and inject glue, infiltrate glue, and these people are cured. But most of the time, it's actually very subtle. Look here, it's MRI lymphangiography, and that's what you have. You have just a tiny dot at the pleural surface. That's enough. This is thing will be leaking. This is a patient with lymphoma, and lymphoma causes obstruction of his thoracic duct. You see, I'm injected it, and it looks kind of normal. Nothing comes out of thoracic duct, but clearly some collaterals here, right? So what we do in this case, you again inject, infiltrate these masses. This is our goal. This is where we're supposed to get. This is with pleural space, like that, right? So our goal is to embolize this mass here. It's challenging. It could be done. It's challenging sometimes, but 99% of it could be done. And this is at the end of injection. So we kind of close it, and he's cured. This is another example of the LAMP patient. And again, look here. This is what you're looking for. It's exactly that. You want to see this pleural perfusion. So this is where he leaks is, and then when we do lymphangiography, you can see here in injecting glue into these masses, and that's what brings her comfort and cure. So again, if you miss this thoracic retroperitoneal to mesenteric, to the mediastinal and embolized thoracic duct, we make things 1,000 times worse. That's the reason it's absolutely imperative to do CT lymphangiography, MR lymphangiography before every thorax. So this is our study we published a few years ago. 51 patients, again, abnormal flow from thoracic duct, from retroperitoneum and callous ascites. Abnormal flow from thoracic duct, we have a 97% resolution, very, very good. And retroperitoneal, 90%. I don't remember why we failed a few cases, but they were, could be successful all 100%. And of course, callous ascites, it's totally different story, and we'll talk about that. Interstitial lymphatic embolization. So we actually accidentally figure out. We thought that if you put a needle into lymph node and inject glue, the needle will glue almost immediately. And accidentally, we injected glue, and it's actually propagated. It's like, oh my God, this is a new technique. And I remember this case very, very well. So we dilute glue a little bit more than for the thoracic duct, 1 to 2, 1 to 3. We started 1 to 6, and then we realized it does not work at all. 1 to 2, 1 to 3, you actually can propagate the glue from lymph node quite far away. And you can use this technique, lymph node, lymphatic masses, of course, liver lymphatic embolization as well. And it gives us crazy amount of options to treat. What do we treat? Callous ascites, for sure. Chylothorax, again, you just saw this example of what we infiltrate lymphatic mass retroperitoneal. Of course, sometimes thoracic duct embolization, you actually can, especially children, can inject from the lymph node all the way into the thoracic duct if you have a small child. I should put a case here, I forgot. You can do Caluria, of course, that's the main thing, besides the retrograde access and through catheter. Protein-losing enteropathy for sure. Groin lymphoria, the most common. Like when you start lymphatic business, you start with groin lymphoria, super easy. And vaginal scrotal lymphoria is quite rare. But they have like 3-4 cases a year. So this is how it looks, right? So this is patient post-nephrectomy. You see this lymphatic mass, you inject glue, and obviously it's all abnormal lymphatics. Sometimes you don't see the leak, you see like abnormal lymphatics. The moment you close them, the things get better. So we'll talk about PLE, Caluria. It's kind of maybe for tomorrow, but we'll talk about groin lymphocells. So this is how it works. So this is anatomy, right? So this is anatomy. Those are first lymph nodes that call sentinel lymph nodes. Usually it's one. And I'll talk about, it's very, very important. We'll talk about them in a second. But everything else, the lymphatics coming from lateral, from medial, through the canal, and go all the way up. Okay? So what's the causes of groin or pelvic lymphorrhea? Pelvic surgery. But most of the time what we see, it's actually kidney transplant, vascular surgery, groin catheterization, primarily by cardiologists, because they deal with heart failure patients and you have enormous lymphatic flow. That's what problem happened. ECMO for sure. And recently we started to see more oncology sentinel lymph node removal, and we'll talk about that. So this is our first case of 1.5 liter leaking from the groin after ECMO, patient post-heart transplant. This is a leak. This is a tiny, tiny thing. And this is so easy to treat. And the other option for this patient, you couldn't do sclerotherapy, it's just hole in the skin. The other option is to do huge surgery or flap. Just to take and put a flap on the tamponade, I guess. That's a technique. And this doesn't work all the time. So we get this patient. So the second one is actually kidney transplant. By now we have almost 40 patients with kidney transplant that we figure out very successfully we treated. And you can see here, I inject Lapidol from sentinel lymph node, the first one, and they actually can propagate the contrast all the way here. And here actually I inject saline, it's D5. And you can see how can I push all the way contrast into the leakage point. And here we inject glue. And most of the time when you do those, it's better to inject glue very, very close to the leak. But unfortunately here there's absolutely no lymph nodes. So we have to inject from here and we do that. So what's the technique? It's a simple procedure, but it took me sweat and many patients to figure out how to do it right. The most important thing is don't play too much with lymph node. If you inject, let's inject a little bit contrast, let's Lapidol, let's do that. At some point you will destroy the lymph node and nothing going to go anywhere. So the general rule, put a needle into lymph node. Right now, of course, we have a hooked one, so it's actually better because the needle doesn't slide out. And you inject, most of the time I inject regular contrast. Sometimes I inject few drops of Lapidol and flush it with saline and show the leak and follow immediately with D5. D5 and glue. Glue dilution 1 to 2, maybe 1 to 3 in this case because it's too far away. Number one. Number two, when you inject, you are committed to your injection. You just keep injecting. Because if you hesitate for a second and the column of propagation of your glue stops, it's immediately polymerized and you're done. That's okay, you didn't reach your goal, right? So you have to be quite committed to injection. Yeah, so, and that's pretty much a thing. Now, the another rule is look different lymph nodes. Of course, if you have a cardiac cuff, usually they cut only one lymphatic vessel. But if you have a kidney transplant, and we see a lot of those again, pretty much 2 or 3 times a month by now, because we started to trust it. It took us like, I don't know, 3 years to convince that that's a good thing. Because if you go to the kidney transplant conferences, we will still talk about lymphocyte coming from the kidney. It's like, no, this is dissection of the lymphatics. It's like, oh no, I mean, I literally go to some meeting and there was a transplant surgeon talking about kidney lymph causing lymphocytes. Like, what is even kidney lymph is? If you tell me what kidney lymph is, Nobel Prize, because it's clearly, it's a very important thing. We don't understand that because it's participating in exchange of the whatever fluid in the kidneys. 100% at some point we will figure out that kidney lymphatics are super important and answer to a lot of kidney diseases, because people in old days actually catheterized kidney lymphatics and showed that kidney generates the same amount of lymph as urine, right? So anyhow, it's all, in these cases, it's not kidney lymph, it's actually lymph from lymph nodes, pretty much 100%. So there's a lot of literature here about a different lymphocyte, because Korean interventional radiologists contribute crazy to that. This, and pretty much everybody's success is very, very high. Different classification and so on. But this is our study where we compare embolization and sclerotherapy. And clinical success was kind of similar, 83 versus 65. Obviously 83 is more, but it's not statistically significant. So we didn't say that we are better. But definitely average procedure rate was less for embolization. Right? Anyhow, all right, so that's easy. You see lymph node, you put a needle inside, inject glue, no problems. Let's say you have a patient coming after a melanoma surgery where they remove melanoma and remove sentinel lymph node. What is sentinel lymph node? It's actually the first lymph node that here, right, that you see. So you don't have a lymph node. How are you going to do that? So all days we develop techniques of what's called percutaneous image-guided lymphatic ligation, where I do pedal lymphangiography, inject contrast, and see in percutaneous ligated. But we don't have equipment any longer. So it was actually not our idea. It was, I didn't put a reference. It's somebody from Belgium. They decided to infiltrate the skin pedal here and did CT lymphangiography and C lymphatics with irregular contrast. But I saw this paper, let's do that. And then I said, like, why shouldn't we do the retromalleolar? Because that's where the plastic surgeon inject their contrast. And specifically, this is a spot between hard skin and soft skin. And look what we got. Beautiful, beautiful lymphangiography here, right? And you can trace it quite well. And actually, you can see exactly where the leak happened. And then you can address that. Yeah, in this case, we cauterized from the cavity and put a, and here I injected, put a cutter, inject glue, but there's a different techniques we can do it, including over-injecting cavity with saline, not saline, with alcohol and just filling with lymphatics. But suddenly we have a new technique. We just, sorry, I keep saying that, we submitted another paper to the JVIR this time around with our first 3 cases, because they've been super successful, great. And the year I didn't have any cases. And suddenly I have 5 in 2 weeks. And it's not, it's like we're still working on it. I think the solution for that, it's not like, you can see a leak, but it's not easy to embolize. But anyhow, it's a work in progress. But please help me with that. But again, what's the technique? The technique is you take a tuberculin syringe or insulin syringe and inject intradermal, literally infiltrate the subdermis. And that's how you got it. And location, this is a key. This is a right location. So if you inject a little bit higher, you wouldn't get that. So abdominal lymphatic leaks. So again, traumatic, not traumatic. Traumatic easy, not traumatic complicated. Callus, not callus. Callus ascites, of course, callus. Not callus, 2 types, liver lymphorrhea and some soft tissue retroperitoneal. Pretty much lymphocell. Non-traumatic, callus ascites and liver lymphorrhea. This is 2 we have at this moment. Maybe we'll have more in the future. We have actually treated few ascites by opening thoracic duct that were not callus, but it's kind of, we still don't know what to do with that. So again, we go back to the same thing. Types of lymph, we repeat the same thing. The moment you have ascites, you remove the fluid and you analyze that. And hold on, more importantly, when people say, oh, I would like to refer to a patient with callus ascites, it's like, okay, give me numbers. No, I don't know numbers. Like everybody's, we know for years it's callus ascites. Yeah. Give me numbers. Until with your eyes you will see the numbers, don't trust anybody, because it will be big professor in thoracic surgery, and at the end of the road, it actually was an intern 5 years ago said it was not callus. So you have to, with your own eyes, see the numbers, because people accidentally confused and whatever, everything. So, of course, mesenteric callus leaks and soft tissue. So we already saw this, just another reminder of the same idea. And you also saw that one, so I will skip on this one. So what the definition of callus ascites, or Kyle? We have no idea. We would know probably very soon, because we actually collected lymph from the thoracic duct and pleural effusion of 50 patients, and we're analyzing that. And I actually tested a lot of different things there. So it's still under analysis. Probably during the CRC next year, I will present the data. Oh, we actually presented last year at CRC, but it was bad analysis, so I have to pull the paper out because I didn't realize that my statistician didn't do the right job. Triglycerides, most important. Probably more than 300-400. If you have a less than 200, it's probably will be not callous ascites, definitely on regular callous fluid, definitely not on regular diet. The number out there is 110, and everybody stick to this number because it's coming from 1966-7 paper from Mayo Clinic, and it's wrong, obviously, because it's fluctuate with the food. For that reason, we also use albumin, and of course, percentage of lymphocytes. And the most important, if you in doubt, give the patient food and feed them. So, because we very, very common see this pitfall, liver cirrhosis ascites and portal mesenteric ascites, occlusion ascites. So, and if you go in the literature, you will see, oh, there's a lot of people, liver cirrhosis causes callous ascites. No, it's not callous ascites. It's chylosish ascites. So the moment you do TIPS, it goes away. The same thing here. So this is the patient that came to us with callous ascites. We look at the numbers, and he's of post-pancreatitis. We realize that he's a narrowing of the SMV. And we stent it, and the callous ascites goes away. So you have to be very, very careful, especially when people go in with the big numbers, and you look, and probably last year I diagnosed 5 or 6 times referral to us. People say, oh, we have callous ascites. Show us the images. Oh, this is liver cirrhosis. Oh, we didn't know about that. Oh, yeah, maybe it's liver cirrhosis. Oh, can you do portal imaging? Can you do transjugular liver biopsy and pressures? Very, 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 very common to confuse ascites of liver and callous ascites. Of course, treatment is totally, totally different. So traumatic callous ascites, it's always come from mesenteric lymph nodes, mesenteric, right? Because it's source of a chyle. And here's the confusion. Sometimes when the people dissect retroperitoneal, cut a huge cavity there, right? And cut mesenteric and retroperitoneal, and you do internal lymphangiography, and you see a huge leak. Oh, great, I got it. You didn't, because there's another leak sits coming from mesenteric. Sometimes you do, and I'll show you in a second. So again, you saw this diagram where's the lymph coming from intestine and meet the retroperitoneal. And of course, when you inject lymph nodes, right, you bypass huge part of the mesenteric lymphatic system. So this is situation number 1. You have, it's a pretty much lymphocell. Surgeon do pelvic surgery, cut the lymphatics, and there's a leak, right? We diagnose easily, no chyle, and we already saw a few cases. And this is just another case of the kidney thing, and you can see it's leaking into the catheter and so on. Easy. This is the second situation. The leak happens after mesenteric lymphatics and intestinal, mesenteric and retroperitoneal lymphatics meet. In that case, intranodal lymphangiography show you a real leak, and you actually can treat it successfully. Here's an example. So this is a patient. We clearly saw a leak somewhere at retroperitoneal, but in mesenteric lymphatics hooked up probably here, because the moment we block this lymph node or treat it, so callous ascites went away. This is typical situation, callous leak. You do liver internal lymphangiography, MRI, everything is perfectly normal, callous ascites. Why? Because leak happened here before it hit the lymphatics. What do you do here? The only answer? Mesenteric lymphangiography. You couldn't do anything else. I mean, potentially you could do retrograde access, but it's complicated. Mesenteric is easier. So, and this is an example. You can see this is leak, and this is mesenteric lymph node, and it's leak here. Okay? And then you have a situation number 3 or 4, where you have a leak, big hole here, and leak from mesenteric and nodal. Whereas people confused because they do that, they actually glue the leak, but we didn't. And this is the guy that already embolized his. We all saw a huge leak in the MRI intranodal, but you can see here we do mesenteric lymphangiography, and this is his leak here. So, and of course, there's something abnormal here. Is no thoracic duct. Obviously, it's not right. And the leak here, and after you inject glue, and we glue this leak. So I didn't show his intranodal images. I probably should, but it was clearly a huge leak on MRI in the cavity from the intranodal. And after we embolized, it didn't work. Oh, actually, sorry. In this case, we even did not do, because I was so convinced that you have to access mesenteric lymph nodes first. We just went immediately with mesenteric lymph nodes and just embolized those. So post-surgical liver lymphorrhea. Where do we see it? Liver transplant, especially children, because the liver is kind of twisted. And surgery for high of the liver, and of course, there's a different topic of spontaneous liver lymphorrhea. So why people, why not every liver transplant has a liver lymphorrhea? Because they cut all these lymphatics, because it has to be something else. What is else? Congestion of the liver. It could be elevated pulmonary pressure, central venous pressure. It could be bad anastomosis, especially in small children when they partially resected liver, so they connect veins, hepatic veins not well, so that's a reason. Hepatitis or liver cirrhosis. So this is our actually first case of liver lymphorrhea, 5 liters a day, and of course, how did I didn't come with this idea? Who came with this idea? Kolb. Why? Because when he developed the new needle for liver focal angiography, he decided that he needs to use the 30-gauge needle to get into the non-dilated liver bile ducts. So, and in his paper in AJR, he actually described that 40% of the time he sees lymphatics, and that's because of that I started to do that. It's all come back to Kolb, right? So anyhow, this is our first case. During the time, I didn't know that we actually can inject glue. Here I use Onyx, right? Because I thought glue is going to embolize, but it worked very, very well. And this is another case of pediatric case of newborn post Kasai procedure, leaking 1/2 liter a day. His weight is like 4 weight like 4 kilos. And the second case, you will see it post-liver transplant. So here we go. We do very easy to do liver lymphangiography because liver lymphatic very dilated. Why? He has a horrible pulmonary hypertension, very elevated central venous pressure. And you can see leak here, you inject glue, the kid is cured. And this is another case of this insanity of the liver transplant. And you can see clearly the leak here. Why is it happening here? Because probably anastomosis is not great. Non-traumatic callous ascites, most difficult condition to treat still. Why? Because it's very hard to identify the leak. Cause of the, most of the time is idiopathic. People just came one day and started to leak. Primarily, we know why, because we block the lymphatic system. Blood malignancies block the lymphatic system. Lymphatic malformation, the same. And this is the most difficult one, the last one, complication of cancer therapy. There's 2 of them. One, they can clog the thoracic duct with clot, and we see a few patients. But more importantly is the immunotherapy obliterates mesenteric lymphatics. And there's a few papers came out recently that's observation papers. Now, we see this callous ascites post Gertruda, right? But we know, because we do lymphangiography, that it's literally obliteration of lymphatics. No contrast propagate from lymph nodes more distally. And there's not that much we can do. We'll try TPA, but not there yet. So again, this is a schematic thing. So causes is obstruction of the thoracic duct, the same retroperitoneal masses because of obstruction, but this obstruction happened at birth, and mesenteric lymphatic obstruction could be just mesenteric lymphangiography, volvulus, or cancer immunotherapy. I just said that. So this is a patient that get port, and you can see thing is hanging here. This is his clot. So the moment to clean it up, we did bypass surgery and remove a port. The callous ascites went away. This is lymphatic masses that leaking, so it's another treatment. It's diagnosis, so we can see the leak here. I don't know, it's not working. You have to trust me. All right, and what's intervention? Of course, obstruction of the thoracic duct, decompression. balloon, TPA, surgery. If you have retroperitoneal lymphatic masses, you can embolize them. It works, but it's stupid, right? You just go and infiltrate these masses because if it's big masses, what I do usually, I use combination of blood as a blood patch, glue, and sometimes sclerotherapy. You just infiltrate these masses and so on. But it's stupid in the sense like you just throw in and hoping it will going to work. It's not very smart. But we do it and it works for majority of the patient if we have these huge, enormous masses, for sure. Mesenteric lymphangiectasia, some people have obstruction, a local obstruction of the lymphatic vessels in the bowel, and they're just sleeping. Volvulus, we have only 2 cases of chronic volvulus that cause obstruction of the mesenteric lymphatics and leakage. And cancer immunotherapy, I already talked to you, Denver shunt right now. This is pretty much the only thing we can do. This is a treatment. You see the previous case. We did this balloon here. And we'll talk about decompression tomorrow, all these techniques. And you can see flow is faster, so the patient is better. So this is intraoperatively. We actually can feed the patient with a cream with sodium black. And this sodium black makes all lymph vessels blue. So you can easily see them and you can operate on them. This is congenital mesenteric lymphatic obstruction. That's normal lymphatic bowel. This is abnormal. And that's what you see. You see these dilated lymphatics and nothing goes to the thoracic duct. Resection of the bowel cure the problem. Mesenteric lymphangiography, for sure, you can see definitely obstructed. You see how horrible, nothing goes to the thoracic duct. And slowly, we'll see in a second, you will see the leak. It's not very clear, but you see how important actually, here it comes. This is a leak. Why this patient has his pancreatitis. And that's how they develop this leak. So here, what we use, Lapidol. This is a 2 situation where Lapidol works, 3 situations, works amazingly well. Because people say, we did lymphangiography and calatoris goes away. Don't trust that. Trust only 3 situations. Neonates with congenital isolated calothorax. You do lymphangiography, it goes away. Obstruction of the thoracic duct and calocystis, of course. Mesenteric lymphangiography, you inject Lapidol, it blocks these tiny leakages. And number 3, liver lymphangiography with Lapidol. Somebody already published paper. And we also do, we don't need glue, you just inject Lapidol, it works quite well. So in this specific situation of mesenteric lymphangiography, again, I will say this word, I hate it. We're about to publish the paper. It's already finalized. It's accepted in SVR about ascites post-liver transplant. And there's 2 persistent ascites. There's 3 causes of that. And I didn't put this data yet. Maybe we'll get tomorrow. Number 1, obstruction of the thoracic duct. In that case, will be Kyle's ascites. And you access mesenteric lymph nodes, you inject Lapidol, it goes to periphery, blocks this lymphatics, and it's getting better. Or you can open thoracic duct, but sometimes it's just obstructed here. And that's number 1. Number 2, liver lymphorrhea. And number 3 will be some portal vein stenosis. So during surgery, you can do mesenteric lymphangiography and inject glue directly into leakage point. So this is our old 2002 presentation, 42 patients. By now, we have almost 80. The numbers not as good as here. Actually, they drop. If we see thoracic duct visualized, it's probably 80%, and here is like more 65%. So we still have a group of people that we cannot treat well with Kyle's ascites. Hopefully, developing all this new imaging will help us out. Thank you very much. Tomorrow will be another day, and I will talk about decompression of the thoracic duct, but I strongly feel that you guys will be doing, all of you, pretty soon, and we're happy to. Yeah.
When you check for liver lymphatics, you not go directly into the bleeding ducts.
Yes, that's the reason we do those. I'm not cardiologist, right? let me just answer. So you just do whatever you know how to biliary ducts look like, and you know how to portal vein. You know that's it. Just figure out. You can get bile ducts occasionally, rarely, but I know that there's a lot of issues with that with other people that are doing that, and they just embolize bile ducts. Whatever.
Sorry, thank you. I just wanted to ask if you had any experience with putting STS into the lymphatic system.
No.
I know some people.
I wouldn't. What kind of? I mean, for masses maybe, like with huge lymphatic masses. I did a few times, but I don't know. So what my technique for these masses is, you first flush everything with D5, clean up, right? Inject glue and push this glue with D5 to the periphery, right? While you already have your micropuncture in the groin, access to blood. You flush this with D5 to the periphery because you don't care embolizing masses. You want to embolize whole coming out of masses, right? And then you infiltrate with blood, and it works very well. So this is like sandwich kind of. D5, clean up the area, glue, push the glue and that works very well. I mean, again, I hate Sotrodeckel or because it's again like it's a crapshoot. There's like sometimes it works, sometimes it doesn't work. With glue, you have I feel much higher chances. This is the only situation. Otherwise, why would you do it? How glue works so well. So if you need to block something.
Thank you.
No, retroperitoneal lymphatics. I mean, you have everything. Sometimes we totally are isolated. Sometimes, and sometimes you actually don't see thoracic duct while doing intranodal lymphangiography, but you do liver and suddenly you see thoracic duct or mesenteric. So sometimes we disconnect, but it doesn't necessarily that people develop lymphedema. I mean, it's just they compensate well.
Then how do we embolize those? Because it may get refluxed into the thoracic duct and further cause the obstruction.
I mean, never been in a situation, but let's think. So one of the things when you try to, as I mentioned it a little bit, if you try to avoid reflux in the thoracic duct, put a cut inside the thoracic duct and inject D5 under pressure, and your glue would never, unless you just inject very, very strong, it wouldn't get it. So sometimes you have like, if you want to go selectively and you just inject, you put the cutter like 3-4 millimeters into the branch and then literally hanging by the hair, and he was like, oh, I'm going to reflux in the thoracic duct. It works amazing ways. Like one of us, usually it's Debbie and me, so Debbie will inject glue and then just pushing the D5. We have like 10 syringes and preventing, and it works. Mm-hmm. So we have 5 patients like that. So, but it's not chylosositis. It's actually liver lymphorrhea. Yeah, liver lymphorrhea. We submitted, again, I hate to do it, submitted. How many times I said it? During the last 1.5 years, suddenly I become much more like pushing my people to submit more papers. 5 cases we do, yeah. So definitely. The albumin, the SAG, small. So when you have so first thing when we have a site, it's not chylous, we will check the albumin, and if albumin is the SAG less than 1, albumin is very high, there's a high chance it's coming from a liver lymphangiography in that case. It's actually Lapidol. We started to use Lapidol, and we accidentally discovered that because we did a guy that can with idiopathic heart failure with horrible ascites, 5, 6, 7 liters a week, but ejection fraction like not bad, like I don't know, 40, 50, I mean, but normal, almost normal. And I said, okay, let's do liver lymphangiography, like with no hope that I will see ever something. I do liver lymphangiectomy, I clear the CV leak, and say, hold on, but with a water-soluble contrast. It's like, okay, let's inject Lapidol, and we brought him to CT actually. Let's inject Lapidol just to see better. It's like, oh yeah, we'll see better. Oh yeah, let's bring him next week, 2 weeks from now for embolization, and next 2 weeks from now, it's like, did he have parasitis? No, great, I don't understand what's going on. And then paper from GVIR came out that we treat post-surgical liver lymphoria with Lapidol, and it's worked. So I kind of, we have since I have 2 cases. Mm-hmm. I mean, we don't embolize liver lymphatic. We only embolize liver lymphatic for liver lymphoria. We never do it for like PLE, for example. For PLE, we use liver lymphatics to show where's the leakage in totem, because our technique is to inject retrograde, right? So I never embolize, besides liver lymphoria or communication between liver through a falciform ligament into the lungs. This is 2 situations where you actually need to do glue. And liver lymphoria, yeah, so it's transition. Meanwhile, I have like 2-3 cases, just Lapidol worked. I don't know, why should we do inject glue? Right. No, Lapidol by itself goes away. But Cooper cells eat it, you know. Oh, it stayed? You said it. So you mean I'm old school, so remember we used to have a CT portogram with we inject Lapidol into the hepatic artery to diagnose HCC, because HCC doesn't Cooper cells that eats Lapidol, right? And everybody, so if 2 weeks later you get CT and there's areas that still Lapidol there, we know it's cancer. Maybe that's the situation. Like Cooper cells didn't find their way to this to eat. And glue stays for sure. Glue can stay for a long time, but Lapidol goes away, eaten up by reticular cells, like Cooper says one place, reticular or something cells.
Thank you for the wonderful talk. 2 questions. Number one, in literature, I've read somewhere between, you said Lapidol, don't trust Lapidol to seal the thoracic duct leak, and literature says somewhere around 50-60%, sometimes 70%. What is your experience? And the second question, I've got one patient who keeps coming back with spontaneous, non-traumatic Kyler ascites, idiopathic. Nothing more I can offer, but how do you approach those cases? Is there anything out of use that you?
So, number one, so first we throw all imaging. Number one, if patient has thoracic duct, clean up thoracic duct. Right now we do it with TPA, right? It's much better than balloon, much better than, if it works, right? We're still learning. TPA within a year, only a year from now. But always I start with TPA, because TPA doesn't cause any damage. The idea is these people develop this Kyler ascites idiopathic because they obstruct the thoracic duct. That's number one. If it does not work, then you do bypass thoracic duct bypass again. That's the first thing. Then you have to get access to mesenteric lymph nodes. So there's 2 situations you can do. I mean, do this at the same time. You know, if you do percutaneous, there's a thin guy. Are you from India or?
Australia.
Australia. I don't know what's the average size of people. So that's it? Abyss country? This also Abyss country? Okay, lucky yes. Yeah. So you can do percutaneously if you're like a thin person. It's difficult. You need to have, not need to have, but you absolutely, okay, I would put it back. The hooked needle, very important, because it's just stay there and then you can inject and inject and inject. Or you just open. I have a 94-year-old, if somebody follows us on Slack, we have a Slack group, discussion group. So the 94-year-old, back surgery, Kyler's leak from the back surgery. Horrible, like 3 liters a day. And I couldn't find any lymph nodes. He's a big guy. Farmer, like he's still working on farms, like driving his whatever tractor. We opened his abdomen actually, like to that, and I found lymph nodes, tiny, inject Lapidol, just Lapidol, because it was far, far away going to the back, and he's cured. So that's so pretty much you have to. It's some type of obstruction, right? Thoracic duct or mesenteric obstruction. But sometimes mesenteric is like totally obstructed, like pancreatitis. That's usually what pancreatitis does. It's just, it's whole lymphatics. Done. Right? And there's no way for them to go, and it's just leaking, because one of the options, you inject Lapidol, it stops this leak, and other collaterals compensate. And so, but do you have a struggle with this patient? Yeah, I have one very, very famous person right now. We're very gentle with her. She's horrible cholelithitis. I already did TPA, didn't work a little bit for a week. She didn't gain any weight, then do balloon. Another 3 weeks, she was symptoms. Monday I'm coming, she was for thoracic duct bypass. And the next step, because I clearly think that she is obstructed, we still don't have a drink yet. So when we have drink, it will like change everything, hopefully. And then next step, open abdomen, because she's big, and I couldn't see any mesenteric lymph nodes. And access these lymph nodes and try to infiltrate, see what you find, and do that. It's a big problem still. We even don't understand where the chyle is generated. Like, it's supposed to be proximal, intestinal, but it's duodenum, or because you theoretically say, okay, let's just cut the like the one that generate chyle, right? Intestinal resection. With drink, this is my huge hope that will make it like closer to 100%. My chaluria is different than Indian chaluria. My chaluria is obstruction of the thoracic duct, reflux into the kidney. There's two techniques. Right now, during the last 7-8 cases, we nailed it down 100%. So we actually don't. I have probably more than that, maybe 15 cases. Last was we all successful. We published 2 papers about that. One retrograde, based on Carlos Guevara idea. And one antegrade. So just so the idea is you have retroperitoneal. I mean, in that case, I'll bring tomorrow. I'll show a few cases. So you have retroperitoneal lymphatics, obstruction of a lymphatic duct. In our cases, it's just obstruction because people were born like that, or clots. In your case, it will be most of it will be filaria, and there's a reflux into the kidney. So the goal is put the needle into these lymphatics and infiltrate glue. And just gently, but sometimes I even don't see this communication. On the MRI, I always see them, but on the lymphangiograph, not always. So I just know approximately and just poke until I find, oops, the one goes over the kidney, inject glue, done. No sclerotherapy, nothing, because a few weeks ago we did sclerotherapy. Patient had been done in our place like 3 times sclerotherapy. It didn't work. I'm not sure where they also injected, but it's, so you have to find this communication between the retroperitoneal and kidney. And it's actually not complicated. I mean, whatever, from our experience. Again, we maybe didn't from totally different animal, because I never had filarious patient. Yeah. It's not chylosositis, it's just chylosisiositis, because liver lymphatics and so what happened is probably there is a congestion of the mesenterium, and mesenterium become a little bit leaky, and ascites become chylous. Why? 200, right? But never go, like if you feed this patient with steaks or whatever, butter chicken, it's not going to go to like 1 gram or 500. It will be like 200. So it's kind of actually liver cirrhosis ascites and not really chylosositis. So, and so the moment, and it's clear, the moment you have patient with liver cirrhosis and portal thrombosis or CMV or IMV thrombosis, you have to take care of that first. Don't do any lymphatic procedures, just making sure you put tips, whatever, do your evaluation, management, and stuff like that. I don't know, there's nobody behind us, right? There's nobody behind us, right? Another lecture?
So in cases of venous thrombosis, subclavian vein thrombosis, that we get the chylothorax or even chylosositis at times, do only the angioplasty or of the venous side, or do you also simultaneously have to embolize the TD or open up the TD?
No, you always try to open it first. Yeah, definitely. So we have multiple cases of SVC syndrome, of course, chylothorax or chylosositis, right? Yeah, even I give a talk about the relationship with the veins, and definitely have pressurized vein, it can cause you chylous leak somewhere, for sure. So first try to open the venous system, 100%.
After opening of the venous system also, a lot of times we are not able to see the thoracic duct. It doesn't get opacified.
What do you mean?
In the post-procedure. Like if you, still there is persistent chylothorax even after opening the venous system, and we do the lymphangiography, MR lymphangiography. There is a lot of collaterals here and there, but the thoracic duct doesn't get opacified.
You don't see opacification of the thoracic duct because it's clogged.
So
again, right now
cases?
it's TPA for me answer. Like immediately, the first thing I will do, I go through phases of something that I love. It's like, oh, this is final solution. The liver lymphangiography was, oh yeah, that's it, the answer for everything. That mesenteric lymphangiography, right now TPA for me, the whole, and then of course, a few years from now, I will say probably it's not going to work. So we do adults like 2 milligram, dwell for 20 minutes, and another 2 milligram and pull out. I'm not sure if it's right. We actually get quite a lot of money from ARPA, where we will do clinical trial, and we do also always analysis of the clots. So if you take clot and I do a lot of harvesting lymph from people, for whatever, 1,000 people at once. So if you don't put it into the EDTA tube, it will clog within 3-4 hours. It will become gel, hard gel. So that's basis of plastic bronchitis, for example. Why plastic bronchitis become plastic bronchitis? And that's what we're going to do. We actually will harvest from pigs and from humans lymph, and we'll try to use different concentration and try to do smarter. We'll also do sophisticated analysis of the clots, understand what's inside. We know it's thrombin mediated. It's there's no platelets, of course, there. It's fibrogen and thrombin. And we have one researcher that think he figured out on like mice, that I'm not sure. Everything that like someone talking about mice. So you know what? If you drop so mice doesn't translate to humans ever, right? Zebrafish or then rats may be bigger than pigs, and then So because if you drop the squirrel from an airplane, it will land no problems. So translation from small animals to humans is very difficult. But he thinks he'd figure out, and he get a lot of money with us together because we're developing lymphatic stent, and he was developing anticoagulation lymphatic. And his anticoagulation is a thrombin inhibitor. So that's what he thinks that, and I think that's what we're going to do as well. So based on the, if we finish with study, we still didn't get us money. Next week they're going to tell us if they're going to deal with like a small piece to whatever big grant. So if we do, so we'll have a lot of answers very soon, because we'll start working already in January. Harvest the clots and do STPAs and stuff like that. Thank you very much. Please come tomorrow. I'll talk a bit more about decompression, protein losing enteropathy, abdominal pain, lymphedema, and so on and so on. And chylorrhea, I guess.